Okay, I will tell you. I'm going to speak. Raise your question.
Now we request Professor Dr. Raja Sabhapathy sir, Dr. Nirmala ma'am, Dr. Aram sir, Dr. Jagan Mogan sir, Dr. G. Kartigeyan sir to take over the dais. Please come to the dais. We also request IMA President Dr. Sendil sir, Dr. Raghuram sir, and Dr. Soundarajan sir to take the dais. Dr. Anand sir, please take the dais, sir. Now we have welcome address delivered by Dr. Kaushik sir.
A very warm good evening to one and all present here. Respected teachers, colleagues, beloved members of IMA Pollachi, online viewers all over Tamil Nadu IMA branches, juniors and postgraduates. It's a very happy moment for us to celebrate the World Plastic Surgery Day, which was coined by none other than our respected Professor Dr. Raja Sabhapathy sir, way back more than 10 years ago, to spread awareness among the other specialties and public regarding what is plastic surgery, because it is the most commonly misunderstood specialty among doctors as well as people. So that has gained global acceptance in the past years, and it is celebrated as World Plastic Surgery Day celebrations, which falls on the July 15th of every year. To commemorate it, we have been conducting regular CME programs for the past 4 years in Pollachi. And it got bigger by the participation of the team Ganga 3 years back. And it got even bigger last year by Dr. Raja Sabhapathy sir's gracious acceptance to start an oration in his name. And this year we have added microsurgery workshop for the postgraduates, and it is growing bigger and bigger in a small branch like Pollachi. So I invite you one and all with love and hospitality to this function and academic feast. I welcome you all for this once again. Thank you.
PPT. It is proud moment for India in the forum of International Federation and Society for Surgery of Hand. Yes, Professor Dr. S.R. Sir has become the president of IFSSH. This is the first time Indian has become president in this international forum. So, on behalf of IMA Pollachi and plastic surgeons of Pollachi, we like to felicitate Professor Dr. S. Raja Sabhapathy, sir. Slide change. Anesthetist of Udumalpet and orthopedic surgeons of Udumalpet like to felicitate Professor Dr. Raja Sabhapathy, sir. Now we have chief guest address by Dr. Aram sir, President of TANPAPS and HOD Department of Plastic Surgery, Madurai Medical College.
IMA members of Pollachi, my teachers, senior professors, and friends from plastic surgery faculty. Good evening. First of all, I thank IMA Pollachi with the great effort of Dr. Kausik, Dr. Purani, and Dr. Sangamitra for organizing such a great event on the eve of Plastic Surgery Day. Plastic Surgery Day was conceptualized by none other than Professor SRS sir to create awareness about plastic surgery and the procedures done in the present era. Plastic surgery is a unique and very wide super specialty unlike others. We operate from head to foot. We do cosmetic, traumatic, post-oncological, post-infective, congenital anomaly reconstructions, from hair transplant to trophic ulcers in tip of toes. Today, the trio team of Pollachi taken great pains to organize microsurgery workshop for our postgraduates from all over Tamil Nadu in free of cost, whereas a regular microsurgical training costs around 30,000 rupees. They have demonstrated various procedures by video also simultaneously. I wholeheartedly appreciate the sincere effort on behalf of Tamil Nadu and Pondicherry Association of Plastic Surgeons. Now, the CME is planned to highlight the different aspects of plastic surgery by eminent plastic surgeons from Tamil Nadu. I am greatly privileged to be a chief guest where my beloved teacher, Professor J. Jaganmohan sir, is giving an oration in the name of plastic surgery icon of India, Professor SRS sir. Thank you one and all.
Thank you, sir. Now I call upon Dr. Raja Sabhapathy sir to address the gathering.
Good evening to all of you. I think it was every year when you come to Pollachi, it's a sense of joy, and every time we feel rejuvenated when you come to Pollachi. So whenever you find people talking about gaps in delivery of surgery, they tell about 3 A's. One is lack of awareness, lack of access, and lack of affordability. I think three things they say. But then all of it starts with lack of awareness. So when I was the president of the APSI, I thought we should bridge this gap by creating a plastic surgery day, because it gives an avenue for everybody, every plastic surgeon to do something. And particularly when everybody does it on the same day, in the same period, the amount of awareness that's created throughout the community is much higher. I think that's the concept with which the days are created. But when we started it, I never could imagine that it would risen up to this much of enthusiasm and proportions. And we should really thank all the plastic surgeons of our country. And in this, I should say that Tamil Nadu leads the way. You will find there's in WhatsApp groups, almost every single major unit in the country, they do something. Either they organize a workshop, they do some CMEs, they make some advertisements, they start new departments, or something they do so that some activity, the culmination of all these activities increase the awareness amongst the people. So in this, I should really congratulate the plastic science of the Pollachi region, Kaushik, Purni, and Sangamitra, and Swarup for doing this. But we shouting ourselves, only we can go to a certain level. But then what they have done is that they have enlisted the support of IMA. IMA is a bigger, greater organization, I think, for which every one of us must be members. I fondly remember my father, where he said that every person who joins our Ganga hospital, he used to ask, are you an IMA member? Whether he is a member of Orthopedic Association or a Plastic Association, first of all, he will say, you must become an IMA member. So I think that's a very important thing that all of us do. And since IMA is the biggest organization in our country, and enlisting the support of IMA, I think it has really takes the Plastic Surgery Day to throughout the country in a much bigger way. I just learned that I think one of the organizers told me that this has created a record this time. The number of viewers for everyday deliberations have been more than 4,000 or 5,000. Sir? Yeah, 3,000, and today I think they're really hitting it much more. And even the Medical Council, Tamil Nadu Medical Council has said there's not a single conference has had so many responses. So I should congratulate the members of that. Yes. I should really congratulate the members of the IMA for this yeoman service they have done to our specialty. Thank you so much, sir. And on behalf of all the plastic surgeons over here, I gratefully acknowledge all that you have done for us, sir. Thank you so much. And I'm sure you will have a good evening. And I'm extremely glad to that Kaushik and team have also done another thing is that get the cream of Tamil Nadu here. I think that's a very amazing thing that they have done, and they do it every year. I think thank you so much, Kaushik, Purni, Sangamitra, and Swarup. Thank you so much for giving this opportunity.
Thank you, sir. It is indeed a great support and encouragement for us to have you here. Next, I call our guest of honor, Dr. Nirmala ma'am, to address the gathering.
Very good evening to one and all present here. Respected dignitaries on the dais and off the dais, plastic surgeons from all over the state and other doctors of from Pollachi as well as from other places. And it gives me immense pleasure in attending this plastic surgery day function, because I thought every week I used to come to Pollachi since it is my own native place. And since Sangamitra called, I made it on, I used to come on every Sunday, but I made it on Saturday today. One thing is I want to tell is because plastic surgery is evolving like anything. And as the speakers told that it is from head to foot they are operating. And many, as Sir told, there is an awareness has to be created. Everything can be, every congenital anomaly or anything can be corrected by plastic surgeries. And also regarding the intersex problems, many people are coming and approaching us that has to be evolved in doing, we have to make the people of have people having the intersex getting more confident, and they are very much mentally worried about their own problem. I have come across many people like that. They seek the help from us, but we don't know how to help it because many are untrained in that thing. So I want all the surgeons, even the general surgeons, should get trained from the plastic surgeons to help them, because they are mentally depressed and they don't know where to go and how to seek the help. Even the government is not able to help them. So we have to take the initiative for that. And also, as the cosmetic and aesthetic procedures are coming every day, and it is updating the knowledge is also very, very important. So such CMEs and the conferences make the people to update their knowledge, what is evolving, and how to keep abreast of what is happening in the medicine. So such CMEs, they have taken every pain to keep the, to arrange this function. I congratulate the Dr. Purani as well as Dr. Sangamitra and Kaushik for having arranged such a wonderful program in our own town of, because Pollachi, I didn't think this much people will come to that in Pollachi. I thought very few people, say maybe around 10 to 20, but I'm very, very happy that seeing so many people are attending the IMA meetings and conferences. So this is the thing we have to follow. And it is one thing that I want to tell is not only the academic knowledge, but also we have to be known to each other for any help. In the era of the medico-legal concerns, lot of people are for even a minor issues, they are creating a problem. So in that way, we have to help each other and we have to protect ourselves. And in this way, such conferences and the meetings, not only to abreast our knowledge, but also to socialize among each other. So once again, I thank the organizers of this meeting. Thank you very much for the invite. Thank you. Thank you.
Thank you very much, ma'am. Your presence has added feathers to the cap. Now, it is immense pleasure for Pollachi to be a platform for the book launch of Tamil version of the AV Fistula Guide. It has been a labor of love for Dr. Nikhil Panse and Dr. G. Karthikeyan sir, with culmination of years of passion to release this book. Over to you, sir.
Before we release the book, Vanakkam, and I am a proud member of the Ambattur branch of the IMA. So greetings to you. And I make it a point to attend this meeting every year for two reasons. The first is to see the youngsters organizing a conference and to learn from how to organize a conference. Even though I have organized many conferences, I still find there is something new to learn. That is the greatness of youngsters doing the work. And I think we can be rest assured that the next generation, plastic surgery is in very good hands, especially in Pollachi. The second reason for coming here is I get to meet a lot of, one was the youngsters, next was the not so young people, like the IMA members here, who are so rich in knowledge and experience. It is nice to interact with them. And that is one of the reasons why I come here. The book, as far as the book is concerned, Raja Sabhapathy sir was talking about increasing awareness. AV fistula creation is very essential for chronic kidney disease patients because that becomes their lifeline. And plastic surgeons, do plastic surgeons do AV fistulas? That is the question. Plastic surgeons are experts in microvascular anastomosis. And AV fistula is nothing but revised microvascular anastomosis. And Dr. Nikhil Panse from Pune has done a lot of surgery along with his mentor, Dr. Parag Sahasrabuddhe. And they have published a book which is mainly for patient information about what is chronic kidney disease, how to take care of the AV fistula, what is AV fistula. And I have had the opportunity, he gave me the opportunity to translate into Tamil. And that is what we have done. I am very glad. I cannot find a better platform than this to present to all the IMA members who are present here and watching online also. I request Dr. Raja Sabhapathy sir to release the book and the respected IMA members on the dais to receive the first copies. So we have both the English and Tamil versions of the book that have been released in very simple language so that the patients can understand what it is. And Madam was talking about small problems coming up. This will not happen if the patients are aware of what is going on, what is the procedure done for them. Thank you very much, sir, for releasing the book. And at this moment, I would like to thank Mr. Rangaraj of La Vincita to have sponsored the printing of this book within a very short time. Thank you very much, sir.
Thank you, sir. Like your YouTube channel, this book is going to enlighten thousands of young surgeons like us. Next, we have Felicitation of Faculties of Microvascular Surgery Workshop.
I request Nirmala ma'am to give the memento to Yelangopuran sir. I request JJM sir to give to Somesh Balakrishnan sir. I request G. Karthikeyan sir to give the memento to Sabari Grish sir. I request Raja Sabhapathy sir to give the memento to Swarup.
Next, I request Dr. Raja Sabhapathy sir to give memento to Dr. Nirmala ma'am. Next, we have vote of thanks for this inaugural ceremony by Dr. Purani ma'am.
Good, good evening to one and all present here, as well as those who have joined us through online. I thank the state IMA office bearers and also Pollachi IMA office bearers and IMA Trust Hall members for providing the hall, as well as for collaborating IMA CGP conference along with plastic surgery celebrations. And the main aim of celebrating Plastic Surgery Day is to create as well as to increase the awareness of the work done by the plastic surgeons. I thank this opportunity I take this opportunity to thank Professor Dr. Nirmala Ma'am, Dean Coimbatore Medical College, for gracing the occasion. I thank Professor Aram sir, President ANPAPS for their gracious presence. I thank Professor SRS sir and James Pandian sir for their presence and guiding us. I thank Professor Jagan Mohan sir for giving their concern for Professor Raja Sabhapathy sir oration for this year. I thank Professor G. Karthikeyan sir, Sabari Grish sir, Ilankumaran sir, Somesh Balakrishnan sir, Raja Shanmugh Krishnan sir, and Swarup sir for sharing their experience and ideas regarding various flap dissections and teaching the nuances in doing microsurgery during the hands-on microsurgery workshop held at morning. I thank Shubhas Kale sir, Ravindra Bharati sir, Jayakumar sir, Ramasamy sir, Sivakumar sir for speaking about the topic on versatility of plastic surgery in today's CME. I thank HODs of all plastic surgery in the medical colleges for permitting their PGs to participate in the workshop and the quiz competition. I thank my seniors, residents who have participated in the workshop in the morning. I thank the IMA members who have joined us in person for this function. I thank the audiovisual team, catering team, and the maintenance team for their support. Finally, I thank all the sponsors. Last but not the least, I thank my team members, Dr. Kaushik, Dr. Sangamitra, and Dr. Swarup sir. Thank you.
Thank you, ma'am. Today, after the microvascular workshop, we had a quiz for the postgraduate students. We are glad to announce the result of the quiz. The winner of the quiz is Dr. Harini, and the runner-up is Dr. Gautam from Erode. OMedic is sponsoring them a microvascular instrument for the winner and the runner. Now, I request the dignitaries to come off the dais to start the oration.
Our next oration is the prestigious Professor S. Raja Sabhapathy sir oration. The orator is our Professor Dr. J. Jagan Mohan sir. And I request Dr. Sangamitra to introduce our speaker, orator.
Video illa.
The video.
A small token of gratitude to you, sir. Professor Dr. Jagan Mohan sir, a fervent teacher, did his MBBS in 1985 from Madras Medical College, MS General Surgery in 1990 from Stanley Medical College, and MCH Plastic Surgery in 1995 from Madras Medical College. Sir joined Tamil Nadu Government Service in 1990, and he had wonderful 16 years of service as assistant professor at Stanley Medical College and pioneered in hand surgery. Then he became associate professor and served at Government Mohan Kumaramangalam Medical College, Salem. He became professor and head Department of Plastic Surgery and Burns at Keelpark Medical College. He was instrumental in the unit's operation to development, including its expansion, and his efforts made significant contribution to turn Keelpark into a center of excellence for burns. From 2014, Sir took charge as professor and HOD, Department of Plastic and Facial-Maxillary Surgery at Madras Medical College. Under his leadership, Tamil Nadu government initiated first transgender clinic of the state at MMC in 2019. He received award of appreciation in 2019 from Government of Tamil Nadu for his outstanding performance in health-related activities. In 2020, Sir held the post of President of TANPAPS and conducted State Plastic Surgery Conference at Chennai. Sir has set foot in various subspecialties of plastic surgery and experienced the essence of various centers of excellence with cordial and benevolent approach wherever he worked. With 32 years and 2 months of service in Government of Tamil Nadu at various prestigious institutions under the guidance of Doyens of Plastic Surgery and journey with various legendary colleagues, Sir has etched his own place everywhere with his kind heart, meticulous mind, perfectness in path, and integrity in ideas. Sir is a certified professional for quality implementation in hospitals and is currently Director of Surgical Specialties at Meenakshi Medical College. Sir is a member of Advisory Board for IJPS and published various papers and articles. When versatility is the theme, who else can be as congruous as Professor Dr. J. Jagan Mohan sir? He is a teacher with firm hand who molds his students to flaunt for flawlessness, to drift with discipline, and prioritize patient care. He has put student and patient welfare in front line during his career. In a nutshell, Professor Dr. J. Jagan Mohan sir is an epitome of perfection, and it is always my privilege and pride to be his student. With overwhelming zeal, I welcome you, sir, to deliver Professor Dr. Raja Sabhapathy oration for the year 2025.
Respected Dean of the Coimbatore Medical College, my plastic surgery colleagues, respected members of the IMA, the organizers, a very good evening to you all. I thank Dr. Kaushik, Dr. Sangamitra, and Dr. Purani for inviting me and for giving me this opportunity to be here. That video clip was totally a surprise to me, Dr. Sangamitra. I do not know from where you got all those pictures. Thank you. Thank you for that nice introduction. The word plastic means to mold. the materials that are flexible and malleable that could be molded are all plastic. In the beginning of the 19th century, a German surgeon by name von Grafe molded the tissues for a reconstruction of a nose. Molded the tissue for reconstruction of a nose. And he named the procedure as rhinoplasty. He borrowed the term plastic from the Greek, plastikos. And 2 decades later, in the 19th century itself, another surgeon wrote a book on plastic surgery, and the term became known to everybody as plastic surgery. It was only in the late part of the 19th century, the material plastic was synthesized. And when they found this polymer could be molded into any shape, the polythene or polyethylene, they too named it as plastic. Maybe at that time, there was no awareness or there was no provision for patenting the term plastic. Now, the general public knows plastic as the material first, before they know that the plastic surgery has been given the name before the material plastic. When you say plastic surgery, people think about cosmetic surgery, which is otherwise known as aesthetic surgery. That's human nature, but because people appreciate beauty and glamour first. So the first thing that comes into your mind when you say plastic surgery is beauty surgery, that is the cosmetic or aesthetic. But there's a much more bigger component in the plastic surgery, that is a reconstructive surgery. Whenever tissues are lost, it is necessary to restore the function and the form. More important, the function, because it is essential that the deformity has to be corrected for the patient to continue with his livelihood. For the person to be independent, when he gets a deformity or defect, it has to be reconstructed. And so the importance, the first priority is to restore the function, and to a certain extent, we also try to restore the form. That is plastic reconstructive surgery. If it's not corrected, the deformity or the defect will worsen and the patient may become a dependent. So reconstructive surgery is quite important. The cosmetic surgery, as such, the function is already there, but there's some disproportion of tissues. Some of the tissues may be large or some of the tissues may be less, and this has to be corrected. Already the function is there, but the form is not satisfactory. It is more important when such form is to be corrected by the plastic surgeon, he has to retain the function which is already there, which should not get compromised when you're. Is the mic working? Okay. So, but sometimes even this, for example, obesity can cause morbidities, which has to be corrected. This is very important for the person for whom the appearance of the personal body is important. The contouring is important to him to continue his profession, to earn his livelihood. Also, it restores the confidence and self-esteem. So the cosmetic surgery Can I continue? Okay. Yeah, it's all right. It's working, it's all right. So cosmetic surgery forms an important part of the plastic surgery as well. So what are the defects and deformities that cause a need for the reconstructive surgery? Trauma is the first and foremost cause for the defects and deformities. Next comes the post-burn contractures and deformities. Next slide. Then there are the congenital deformities that can be corrected by plastic surgery. Then the post-excisional defects of tumors, both benign and malignant, need plastic surgery. Then comes the infections, the tissue defects caused by the infection with various microorganisms, especially in immunocompromised states or diabetic foot, or in the case of, say, filariasis, mucormycosis, so Hansen's, all these cause tissue defects, which can be corrected by plastic reconstructive surgery. So these are the various subspecialties of plastic surgery from head to foot, or rather I should say from hair to toenail, because we do hair transplants too. So the plastic surgeon has got the opportunity to enter into the surgical theaters of all other specialties in order to perform some part of plastic surgery in a multi-specialty hospital. So now I'll give you an overview of many of the procedures we do from head to foot. Starting from the scalp, there's a defect in the scalp which can be corrected by rotating a rest of the scalp is a rotation flap. The advantage of this is that there is no secondary defect that need to be covered by a skin graft. Here, especially in ENT surgery, a defect. I mean, especially after placing a cochlear implant in the post-auricular region, because of the pressure necrosis, there could be a necrosis of the scalp tissue with infection. In that case, this implant cannot be removed because of infection, because it's a very expensive one. So we have to debride and maintain the implant in situ, whereas we have to cover the tissues. Here, this rotation flaps becomes very handy, and it can be covered without any secondary defect. This is a defect. When the defect is smaller or in the central part, we do a transposition flap, but the secondary defect has to be covered with a skin graft. But this can be dealt later. That area need not be alopecia all the time. This I can show with the next picture. This is a post-burn scalp scar, which has caused alopecia in the temporoparietal region. Now you can see the hair-bearing scalp has been expanded with a tissue expander. What you see there, this is the tissue expander. The mouse is not working. Mouse is not working. Can you make the mouse work? I want to do. Can I have that connected mouse? So you can see the tissue has been expanded by periodical injections with saline. Once the expansion is adequate, then we can remove the expander, excise the scar, and then tape the defect with the hair-bearing scalp. You can see in last picture, it's been covered. Facial injuries are very grotesque in the beginning, but with adequate care and by strategic placement of scars, they can be made to heal well because the face has got a good vascularity. Here is a case of a very bad nose laceration where the injury has gone right up to the cartilage, but accurate repositioning of tissues is important for us to get back the facial appearance. For this, we need a good knowledge of anatomy, and the plastic surgeon has got an anatomy of, knows the anatomy of even the subunits of the facial tissues. replacing them, we can minimize the scars. And especially the nose being the most prominent part of the face, the scars are very conspicuous, and this can be made lighter by good suturing, meticulous care. This is a defect of the tip of the nose. What you see next is the final picture. The intermediate pictures you see below it's called, we have raised oblique forehead flap that has been transferred in stages, and finally the nose tip is reconstructed. There's another case where it's a paramedian forehead flap has been used. This is a classical Indian rhinoplasty. This surgery has been designed by the Indian surgeons, which later the Britishers copied, and it has come, they published it, but they published it with respect to the Indian surgeons, calling it as Indian rhinoplasty. Here is a patient where only the ala is a defective, which has been corrected with a nasolabial flap. And this is also done in stages, and you can see the final pictures below. Only the ala has been reconstructed. And again, the ear injuries requires first an assessment of the vascularity of the tissue, and a plastic surgeon can do a good job because of the meticulous use of fine suture material, and with necessary magnification, they can anatomically replace the tissues in the exact place, anatomical location, so that the scars are minimal and are not conspicuous. Here's the ear reconstruction. Two different cases, reconstructed with a post-auricular flap. What you see below is done in the acute stage. This woman has been robbed. Her earrings has been snatched off by a robber. She lost her purse and she lost her earlobe as well. But at least we could get back her earlobe at the earliest, that is at the emergency stage itself. So she would have had some psychological comfort of not being disfigured by that incident. This is a congenital defect called microtia, where the ear is not developed adequately. So the cartilage from the chest has been harvested, designed into an ear, and the ear has been reconstructed. This is done in multiple stages to get a final good result. This is a congenital ptosis, where the upper eyelid is weak because of the weakness of the levator palpebrae superioris. So the child is not able to open the eye on the left side. If it is not attended to early, the child may develop lazy amblyopia, lose vision in eye in due course. So it has to be corrected at the earliest. We have harvested the palmaris longus graft from the forearm and use it as a sling to anchor it to the frontalis muscle, so the child is able to open the eyes. Here you can see the lower eyelid reconstruction being done. Here this patient has lost the outer skin and the muscle layer and the tarsal plate, but there is some conjunctiva left. So we designed an eyelid from the forehead. In the third picture, you can see the shape of the eyelid has been designed in the flap itself with a subcutaneous pedicle bearing a vessel. It's the axial pattern flap that has been channeled at the bridge of the nose, and the last picture, the eyelid has been reconstructed. This is a BCC in the infraorbital region that has been excised, and the tissues has been adjusted to cover the defect, and over a period of time, you can see it's almost, the scars are not visible. Cleft lip and palate are one of the major fields where the plastic surgeons play a major role. And this, what you see there is a Miller type of repair. And in the third picture, you can see the white roll. This approximation of the white roll is most important because this is called the $1 million stitch. If it is not done correctly, this disfigurement is going to be there forever, and patient is not going to be satisfied. This accurate placement of the white roll and reconstruction of that Cupid's peak is quite important in getting a good appearance for the patient. We do more than one type of cleft lip repair. This other type by which lip can be repaired. Depending upon the indications and presentation, we choose the type of repair. This is a triangular flap repair. Then here is the palatal defect. The palate has to be repaired as early as 18 months, and so now it is being done even at the age of 1 year because the speech has to be restored as early as possible in order for the patient to develop good speech. So in the post-operative picture, you can see the defect is closed by the mobilization of the mucoperiosteal flaps. This is a CHTK, malignancy, a squamous cell carcinoma at the angle of the mouth that has been excised, and a flap has been raised from the lower lip and transposed into the defect. And this requires a good knowledge of the vascular supply because the flaps are meaningful only if the blood supply is retained. This is a classical geo of the pectoralis major island flap and the delta pectoral faciocutaneous flap for reconstruction of the defects of the cheek. In this patient, the patient had the skin intact, so only he had a lining defect, the mucosal defect and the buccinator muscle, the muscles of the cheek were excised, and so he required only a lining. For that, we have raised these pectoralis major muscle flap, a myocutaneous flap, and the skin becomes a lining on the inner aspect. The delta pectoralis flap is also there preserved, which can be used if there's a cover defect as well. The plastic surgeons fix also the bones, all the facial bones, the bones of the hand and the bones of the feet, all can be fixed by the plastic surgeon. Here you can see the fixation of the orbital region, fixation of the maxilla, fixation of the mandible, and with plate and screws, and there you see the patient restored. That is, not only good mouth opening should be there, the teeth occlusion should be intact. For any facial maxillary surgery, the function has to be maintained. This is one of the challenging cases because it involves the condyles. The condyles, we have to operate through a small keyhole in the retromandibular region or in the preauricular region to get access to the small fracture fragment that is so deep inside the temporal fossa. And it is also, the facial nerve is at risk. So we should have a good knowledge of anatomy to get back this fragment into position and fix it back into the mandible. And this is a bilateral condylar fracture that has been treated surgically. Nasal bone fractures also, this has been treated conservatively just by manipulation by using appropriate instruments. This can be done and even under local anesthesia, where a fractured nose, the pyramid of the nose is restructured back, brought back to position. So when you see such facial-maxillary injuries, it requires a lot of work. First, the facial skeleton has to be reconstructed, and then the skin, everything has to be put back in place to get a good result. But what everybody should know who's working in emergency is that whenever such major cases of facial maxillary injury comes in, the basics of emergency care, ABC, airway, breathing, and circulation is to be seen whether it's intact. So the mouth has to be opened by the emergency, whoever's attending to the emergency, and look for broken teeth or dentures. And ideally, that long forceps should be there for removal of these foreign bodies. And then if the maxilla is fractured, then it can slide back and go and obstruct the pharynx, the oropharynx, because the soft palate is just behind the maxilla. The soft palate can go and occlude it. So it is necessary to pull back the maxilla as early as possible. For this, we should have ideally that Rowe's disimpaction forceps. Even if that forceps is not there, all you can do is put your fingers and the thumb, hold the maxilla and pull it forward, and then put in an airway for the patient to breathe. Similarly, when there's a bilateral fracture of the mandible can slide back along with the tongue which is attached to it and obstruct the oropharynx. So the mandible has to be pulled forward and then the airway has to be put in. If there are no risk of spinal injuries, then tilting the neck backwards, tilting the head backwards and pulling the mandible forward is easier and the airway is put. But when there is a risk of spinal injuries, neck extension should not be done. This is a sort of aesthetic surgery where the maxilla and the mandible are disproportionate. So there could be a retrusion or there could be a protrusion. So this can be osteotomized appropriately and can be realigned. Again, the occlusion has to be correct. When you regain the facial appearance, the occlusion of the teeth also has to be attended to. On the top row, you see the preoperative pictures where there's a mandibular prognatism. The mandible is protruding and this mandible has been osteotomized and set back. And occlusion also, post-operative, you can see there's no more malocclusion. In the neck, when the ENT surgeons do a excision, when they do this is a case of a total laryngectomy done by ENT surgeons. And for the reconstruction, this is an end tracheostomy there. There is no more upper respiratory passage, in the neck region. So we have covered it with a deltopectoral flap. Again, this is a case where, again, a total case of total laryngectomy with an end tracheostomy. But here, there's a pharyngocutaneous fistula. Now the trachea is gone. There's a fistula there. And so we use the deltopectoral flap in the reverse so that the skin goes for a lining and the undersurface is now covered with a graft. And this is a two-stage procedure for coverage of the defect. The neck contractures are the most common contractures which deal with in the post-burn period. And you can see that contraction has been released and covered with a skin graft. A skin graft is quite thin and gives a good contour for the neck. But it has to be taken care adequately in the post-operative period by giving a splint for a minimum period of 6 months. Otherwise, the contraction can recur. When the defect is confined to one region, then we can always use a flap. What you see is a supraclavicular flap, the flap that extends into the shoulder based on the supraclavicular artery that is transposed after the excision of the scar, and the donor area is covered with a skin graft. So for brachial plexus injuries, we operate in the neck, and the type of surgeries we do are neurolysis or neuroraphy, a nerve anastomosis, or more often we don't find the root. So we do a nerve transfer. A functioning nerve is now transferred to a muscle that is paralyzed. So the nerve transfer, and what you see is a spinal accessory nerve transfer to a suprascapular nerve for shoulder abduction. And if even a donor nerve is not available, straight away we can go to the end organ, the muscle transfer. Here you can see the trapezius muscle is transferred to the deltoid for a shoulder abduction. So here is an arm defect. In the lower row, on the left side, you can see an arm. The humerus is exposed. The humerus is exposed without any soft tissue. So we have raised the latissimus dorsi muscle, that is, you can see the first picture, and the second picture, the muscle is raised and is transposed to cover and save the humerus over which we apply the graft. This case, you can see, right from the skin to the bone, everything is injured. So here, the plastic surgeon can work on his own for managing all the tissues, right? First, he fixes the bone, then he does the tendon repair, the nerve repair, and the vessel repair to get the distal tissue revascularized. And for any tissue defects, skin defects, we have got multitude of flaps. What you see is a straight triangular flap for the thumb tip, then a first dorsal metacarpal artery flap for the dorsal aspect of the thumb, The most commonly done, the cross finger flap for the volar aspect of the finger. Then what below you see the neurovascular island flap, where we need to provide sensation to the tip of the thumb. It's very important to provide sensation. Then when the defects are large, we take the regional flaps from the same limb. What you see is a posterior interosseous artery flap taken from the dorsal aspect of the forearm to cover a defect in the dorsum of the hand. And here's a tubed groin flap. What you see is a ring avulsion injury. What I want to say, what I should tell this general public, what I want everybody to know, a ring is a potential weapon worn in the hand. So I would advise, unless it's very important, it's better to wear the ring only for special occasions. When it is necessary to wear the ring all the time, at least let them take care that at least they should not travel in the bus, because we see these injuries more commonly when people getting down from the bus, the ring getting caught in a hook somewhere in the bus, and while they're getting down, the skin gets degloved. More often, it's difficult to reimplant the skin because it will not have any blood vessels, and usually at the site of injury, it's crushed. So you should always be beware about while wearing a ring. And here is a tubed groin flap that has been used to cover the defect. And the groin and the abdomen provide abundance of skin for us to cover the defects of the hand. They are the workhorse for covering the defects in the hand. Here you can design a little bit of these flaps if you are well aware about the blood supply, the circulation. So you can see that it has been slightly designed to fit the defect in the fingers. And here is a superior base abdominal flap also been designed. And there's a bipedical flap where you need to cover the flap for all the 4 fingers. And individually fingers can also be covered with these lower flaps if the defects are more distal, so that we can spread out the fingers and cover them. And when there's a bone defect, it can be made good by a free bone graft. That is, the ulnar bone graft, it can be taken, is shown here, is harvested, and a defect in the proximal phalanx, we use a fixator to reposition and stabilize until the bone gets organized. We can use the fixator. Again, what we should teach people is not to apply a tourniquet like this when there is an injury on the roadside or in an emergency situation. These tourniquets you see are indigenous ones using odd objects like cloth. What happens when you apply a tourniquet, it is not going to occlude the artery, but it's going to occlude the vein. So the limb is going to get congested and bleed more. And below you see a very tight tourniquet. When you apply such a tight tourniquet, it is of course will obstruct the artery also, but it is going to damage the artery and also the nerves traveling along with it. So such tourniquets indigenous tourniquets should never be applied by anyone, by lay people. So what need to be done is the local compression to be applied with a dressing, and the hand is to be elevated. Once the limb is elevated, the bleeding becomes less, and local at the site of the wound, a compression dressing is to be applied. If at all there is arterial bleed, a tourniquet is to be applied. It should be done only by a member of the medical profession with a pneumatic tourniquet that may be available in an ambulance. And again, when the patient comes to the emergency medical department, when you open a dressing and the artery starts spurting out, it should be clamped with an artery forceps in an unanesthetic patient. Because when you apply an artery forceps, the patient will wriggle the hand and you are going to crush the nerve that is traveling along with the artery. So never do it, reapply it. Maybe you can apply a pneumatic tourniquet. When you apply it, see that it is released every 30 minutes until the patient is taken into the emergency theater. Then this is a secondary tendon reconstruction where a tendon has been damaged. So the space has been created by keeping a silicone rod and later replaced with a tendon graft. We do surgeries for Hansen's patients also. Patients for the intrinsic minus deformity for a because of paralysis of the ulnar and the median nerves, the patient develops a claw hand. Here, what you see is called as a lasso procedure, by which the intrinsic plus position has been regained. This is a partial amputation. Almost all tissues has been cut except for a small skin breach. Again, when anybody sees such a patient, it is important. Being just thinking this is only a small skin bridge, it should not be cut. Maybe for the convenience of transportation, nobody should cut that skin bridge, because that may contain the important vital element called the veins, which will drain, which is most of the, if at all any replant fails, it is mostly because of the venous anastomosis not functioning. If there is an existing vein like this in a tissue, it should be only the arm has to be splinted and transported. Here, the bones are fixed first, then the vessel anastomosis is done. If there is a defect in the artery or vein, both can be reconstructed with a vein graft, maybe a saphenous vein graft harvested from the leg. And similarly, for the nerve defect is there, it can be made good with a nerve graft, such as sural nerve graft, again taken from the leg. So having done all the fixation, there's a skin defect, still the plastic surgeon can provide that too by providing an optimal skin cover. So here's a thumb that has been replanted. And here is a bilateral hand amputation. This is a 66-year-old patient who was binding the books. He accidentally sustained this both hand amputation. And what you should know is that sometimes the amputate arrives first. So the dissection of the amputate starts before even the patient comes into the operation theater. The patient has to be resuscitated, and he has to get some blood transfusion. He has to be assessed by the anesthetist. So it will take time for the patient to come in. By the time the amputate is dissected, the arteries, the nerves, the tendons, all are dissected and kept ready for replantation. These are the replanted hands. And what you should know about everybody, the tissue, the transportation of the amputate, the amputated tissues. These tissues should not be directly put into water or over the ice. So what should ideally be done is to wrap it in a plastic cover and then put it in ice. If it is a small amputate, you can put it inside a flask, or if it is a large arm, it should be carried in a thermocol box. Here is a patient who has got Binder's syndrome, where there's a depression of the nose. We have harvested the rib and shaped into a bone. She also had maxillary retrusion. So the maxilla has been augmented with the maxillary platform has been augmented with a bone segment. There you can see that posted with the pictures below. And then the dorsum has been augmented with a bone graft. And what you see in this lower row is post-operative pictures. You can compare them with the pre-operative pictures. One of the commonest things which young male adults suffer, or even other age groups also have, this gynecomastia is an easily treatable condition. Without damaging the nipple, we can take off all the male breast tissue by means of a liposuction. And this is virginal breast hypertrophy, where around the time of puberty, young girls may develop. This will cause not only embarrassment, but also it will produce back pain, their skin infection under the breast, a lot of difficulties. So what was shown in the pictures is a superior pedicle technique, where we preserve the nipple on a superior pedicle. At the same time, the remaining breast tissue is reconstituted and the function is retained. For lactation can be retained because the breast tissue is still there. It is important whenever aesthetic surgery is done, the existing function has to be retained. And when there's for small breasts, we can always augment with implants. What you see is a silicone implants. And nowadays, expandable implants are also available, which can be pushed through the axilla without causing any scar beneath the breast. So another question which the generally people ask is whether we use plastics. That is, because it's called plastic surgery, whether we're using plastics. Yes, some of the implants are made of plastics, but we use a number of other implants also, metals, ceramic, plastic, then silicon. What you saw is a silicon. It's also a type of a polymer. Plastic is also a type of a polymer. But what we use as implants is high quality polymers, which are biocompatible. And here's a body contouring done where the excess fat can be suctioned off by means of a liposuction and the scars are not visible. This type of cases we get from the cardiothoracic department. A patient has undergone an open heart surgery where the entire, because of the infection, postoperative infection, the sternum has necrosed. So we had to recover we had to debride, and there was no sternum there at all. The mediastinum is exposed. So we took the transverse abdominal flap, and we have transposed based on the superior epigastric vessels. We have transposed this. What you see, the part of the flap which is distal most from the pedicle, we know that it has got a poor blood supply, and we have took some chance and put it there. But as we thought, as we have anticipated, the superiormost part necrosed. But we have other flaps too. We use the pectoralis major to cover that defect which was caused by the necrosis of the tram flap, and we covered that. Here you cannot expect cosmesis because this is life-saving. The mediastinum is exposed. We have to reconstruct with a flap. Here the function has to be restored. The patient has to be saved. So to maximum extent possible, we try to make all flaps cosmetic also, but it's not always possible. Acute burns is one condition where the plastic surgeon turns into a physician, where he calculates the fluids, takes care of antibiotics, various parameters, checks the various parameters, and treats a burn patient. The patient is put under plastic surgeon because the plastic surgeon can intervene at the earliest when the tissue defects occur, especially in the case of electrical burns or respiratory burns, or because the plastic surgeon will know at the earliest when can he interview that there's no delay in giving a cover to the burn wounds because they are detrimental for the survival of the patient. Of course, we are helped. We have a lot of interaction with physicians in this, with all specialties of the medicine when we are managing acute burns, and we are thankful to the physicians as well because they help us, they guide us, especially when the patient develops renal problems, hepatic problems, etc. So this is, you see, there's extensive burns. They're all well granulated, fit for grafting. But where to get the graft from? Can the patient have all the graft to cover this area? This is where skin banks comes into play. That is, from the cadavers, the skin grafts can be harvested and stored. They can be stored with 85% glycerol as long as 5 years. The importance of the skin is that, not that the problem becomes easily solved by applying the homografts. It's not that all the raw area can be covered with graft because these application of these homografts are only temporary. When we apply such grafts, we apply the patient's own graft, and in between we apply this homografts so that these homografts may stay there for about 2 weeks' time or so, but later it will fall off. Then why do we apply these homografts? It's because this is the time. These homografts has the ability to control protein loss and water loss. They serve as a barrier for microbial infections, and they improve the nutrition of the patient. It reduces the pain. So the patient becomes more cooperative and the patient's well-being improves. And so by the time when it falls off, the donor site of the skin graft were healed, we can reharvest the skin graft and again cover the defects. So what is the first aid? The first aid is only water, water, water for any burns. We see a lot of patients applying flour or a lot of this butter or something. These vegetative products have microorganisms, so they never should be applied. In an immunocompromised patient, they can produce skin infections. So it should never be done. And so what needs to be done is to wash the wounds and then cover with a clean cloth and send it to a medical officer. The other problem we face is the application of the ink. Ink has no antiseptic properties and it only makes our work difficult because it stains all the burn wounds. We are not able to calculate the surface area and the depth, which are important for the management of burns. So ink should never be applied. And these are the abnormal hernias, which with or without mesh we operate. What you see is a component separation technique where the internal oblique is separated from the external oblique. So many times we'll be able to close without a mesh because it releases the tension on the wounds. Here you see what you see in paraplegics and debilitated patients, the pressure source, the sacral pressure source treated with gluteus maximus myocutaneous flaps. And here's a ischial pressure source treated with a biceps femoris advancement flap. And this is one field which is also the urologists manage as well as we too manage this hypospadias cases. Here is a distal case of hypospadias where we have turned a flap. It's called a Matthew repair and it is done in one stage because there's not much cardi here. Whereas this patient has got a cardi. So first the cardi has been released and covered with a skin graft. In the second stage, the urethroplasty has been done. So we also go to the gynecologists to treat cases of this like vaginal atresia. This patient has no uterus, no vagina, but in order to produce a serviceable vagina, we have reconstructed it by doing a dissection, creating a pouch between the bladder and the rectum and covered with a skin graft. And it can also be done with flaps. And what you see there is a conformer that is to maintain the space. It should be used for the mold. It should be used for some time for the maintenance of the organ that is being reconstructed. Now here come to the lower limb reconstruction. We have got a multitude of flaps. Here you see the gastrocnemius muscle flap and the myocutaneous flap. And here is the faciocutaneous flap, the nasal artery flap, which is most commonly done. And a bipedical flap to cover the defects over the tibia. And a cross-leg flap. Of course, this cross-leg flap is not so frequently done. With the advent of microvascular surgery. This is not really being done because the positioning is quite difficult and it can be maintained only by children. But it sometimes comes as a savior when a flap fails. And this is the only source by which we can cover the defect. Or the patients who refuse microvascular surgery. And the microvascular free flaps are not only these, especially when a bone is required somewhere, anywhere in the body, the osteocutaneous flap, the most commonly done, the fibular osteocutaneous flap, is raised by the plastic surgeon. And whichever surgeon requires a bone anywhere, the plastic surgeon provides the fibular osteocutaneous flap. Then we do functional muscle transfers, then from toe to hand transfer for thumb reconstruction. And recently, we have started doing hand transplantation as well. Then the rest of the defects, the plastic surgeon also repairs the Achilles tendon, where you see the tendon has been repaired, and then it is further reinforced with a facial lateral graft. Plastic surgeon fixes also the fractures in the foot. Again, what everybody should know, this is an open degloving injury. Everybody knows the skin has been lost, the tissues has been lost. But what people should know is about the closed degloving injuries, where you see the skin is degloved and come back to its original position. So here the skin is non-viable. If it is not recognized, it may produce infection. This is because of the called as Moll-Lavallee mechanism. That is, the degloved skin rotates and comes back to this position. The blood vessels are sheared, already damaged. So the skin is non-viable. There's a hematoma underneath. The non-viable skin and the hematoma are potential factors that invite infection. If it is not recognized early, it may produce profound infection. Again, for the treatment of filarial leg, it is done in various stages. We should have a good knowledge about the vascularity so that we know which part can be thinned out. And then by doing this reconstruction, we should not lose the skin flaps because in a lymphedema limb, a raw area becomes even more worse. And here's a squamous cell carcinoma involving the heel. So that has been excised and the flap has been raised from the instep. The instep flap is not a weight-bearing area, so it can be transposed and it can be covered with a skin graft. That is what has been done here. Now, this is a patient who had a total amputation of the foot, just above the ankle. It has been fixed. And all tendons, vessels, nerves, everything repaired. And this is the first time he is walking without support. You can see the patient is taking steps slow and steady. There is some weakness of dorsiflexion. That is because of the scar there, which is there was a wound adhesions which I got is a skin graft. So later, this dorsiflexion also is improved. As such, there is no foot lock. I once again thank plastic surgeons of Pollachi, Dr. Kaushik, Dr. Sangamitra, and Dr. Purni, and the members of the IMA for inviting me here. Thank you all for patient listening. Thank you so much.
Thank you very much, sir. You have taken us all through all the nook and corners of plastic surgery. It was like a quick revision of 6 volumes of Peter C. Nelligan. Thank you, sir. Now, I request Professor Dr. S. Raja Sabhapathy, sir, to honor Professor Jagan Mohan, sir, with a medal.
Thank you, sir. Friends, that is the 3 decades of experience, putting into a nutshell the experience of plastic surgery from head to toe, proving the versatility of the branch. And now I request Dr. Jay Kumar to give the next speech. And we take great pleasure in welcoming our state IMA president, Dr. Sengutran sir, and the whole team of IMA, comprising our secretary, Dr. Karthik Prabhu, our finance secretary, Dr. Gauri Shankar, our past national vice president, Dr. Prakasam sir, and NRTS sir. Friends, Dr. Jay Kumar is a plastic surgeon who has done his MBBS from Madurai Medical College, did his DRTO in JIPMA Pondicherry, MS General Surgery from Madurai Medical College, and MSH Plastic Surgery from Stanley Medical College. He has got a vast teaching experience over 16 years, and he has got so many credits in his name, and he has been the organizing secretary of the International Society of Surgery for the Hand and organizing secretary of the Tamil Nadu and Pondicherry Association of Plastic Surgeons, and organized many CMEs. And his special interest is being hand and microsurgery, brachial plexus surgery, and hand transplant and cosmetic surgery. And today he has come here to talk about the hand and foot reconstruction. And plastic surgeons have always been passionate in treating the deformities of the hand right from the days of the menace of leprosy. And many plastic surgeons are given the function back to the people who have been affected by the leprosy. And now the scenario has changed, and same kind of problems we are seeing in the foot in the form of diabetic foot. And Dr. Jayakumar is the right person to talk about that. And we welcome Dr. Jayakumar to give the speech. Thank you.
Thank you. Thank you for wonderful introduction. Respected senior plastic surgeons and IMA members, both online and offline, and friends and postgraduates. Already, Dr. Jagan Mohan sir, he covered all the topic, almost from head to foot. I will be speaking something for something about hand surgery for general practitioners. Next slide. So versatility, what is it? It's a bit term to be for plastic surgeon, because already we discussed, no, plastic surgeons, they are operating from head to foot, not like cardiovascular surgeon, they will be operating only heart. Neurologist, cardiothoracic surgeon, they will be only operating heart, but plastic surgeon, they will be operating head to foot. Next slide. So you can see all variety of deformities from head to foot. It is vascular malformation of eyelid, so starting from vascular malformation of eyelid, congenital radial club of both hands, carcinoma cheek, and AV malformation of hand, and BCC of nose. So post-mastectomy defect. All these things can be reconstructed by plastic surgeons. So briefly, hand anatomy, hand is a very intricate structures which has a lot of bones, nerves, all these things. We are reconstructing everything. So starting from simple thing, so there's a small laceration over the ring finger. It looks very simple, but there is a cut injury of skin, nail bed, nail avulsion, and there's a fracture of TPX bone. So it looks very simple, but all these things to be taken care of that. Only plastic surgeons can do this type of work, because plastic surgeons, they can do surgery under loop magnification, good light, as well as under tourniquet. So they will have a good facility. So what you have to do, you have to do nail bed repair and nail reposition, as well as fracture management also. So this is a final picture. So this is another case of post-traumatic defect over the little finger with exposed tendon, which was reconstructed with a posterior interosseous artery flap cover. It's a thin flayable flap, so it looks like normal skin. So coming to little proximal, there is a post-traumatic defect over the proximal forearm with the exposed tendon and bone, which was covered with the abdominal flap. What is abdominal flap cover? We will attach the hand with the abdomen. We will retain for 2 weeks. After that, we will divide that. That abdominal skin will come to the forearm. This is the abdominal settle abdominal flap. The multiple tumors, starting from benign tumor up to cancer, we will operate. This is a case of glomus tumor. It's a very, very uncommon problem, which patient will have excruciating pain over the nail bed. Most of the time, patient will be roaming around here and there without diagnosing the glomus tumor. MRI is the diagnostic tool. We can do excision. Most of the time, the glomus tumor arising from the nail bed. So superficially, it will not be seen. So we have to open the nail and nail bed. We have to excise the tumor in toto. After that, we can close the skin. So lipoma, it's a common problem. One more thing is giant cell tumor. It's a giant cell tumor involving the tendon seat, which transfers wherever the tendon goes along the synovium. So multiple nodules will be there. It has to be excised in toto. Otherwise, recurrence is very, very common. So radial congenital anomalies, we are seeing a lot of cases. It's a radial club gun where the wrist is bent opposite side, 90 degrees, it will be flexed. So what we have to do is we do corrective cast for 2 to 3 settings, then we can make it straight. After that, we will operate what is called radialization of ulna. We'll make the hand into straight. So same patient, after making the straight, the patient is having only 4 fingers. The thumb is totally absent. So what we have done, it's called policization. We will make index finger as a thumb. Video, you can play the video. So this is 3-year-old child. After radialization, we made index as a thumb finger. This patient is having good movement, thumb opposition with all other fingers. The same thing for syndactyly. Syndactyly means fusion of 2 fingers. It's very, very common problem. Most of the time it will be bilateral. So we have to release the Sometimes we will release with skin graft. Sometimes we will close it primarily without skin graft. This has to be done within 1.5 to 2 years. Otherwise, it will prevent the growth of the child. Burns contracture, we can see extensive contracture of the hand. The contracture is released and we can do flap cover, either abdominal flap or free flap. This is a case of axillary contracture, which was released totally with skin graft is applied. Thumb pre-plan, J. James already discussed. It is an interstitial accident at the level of PPX of the thumb. It was replanted and the thumb video is not working. So come to little proximal level, it's an interstitial accident of forearm total amputation. So this is replant timing is very, very important. If you do within 6 hours, you'll have an excellent result. So most of the time, the transport also very important. Already Dr. JJM discussed about how to pack and transport all the things. Within 6 hours, if you re-establish blood supply, the results are good. If you delay it, there will be a lot of complications. After 12 hours, undiagnosed compartment syndrome, all these things. This patient we did after 6 hours, but the result is okay. He's a happy patient. One more common thing is toe transfer. When there is no fingers for all 4 fingers are lost, we'll take a second toe from the foot. We'll do toe transfer. Video. Second one, yes. So upper one is not working. So toe transfer also is a common procedure for finger. This is one more case of arm replant. This is a man working in lift. He got amputation of right upper limb at the level of arm. It's proximal arm. You can see the proximal humerus level arm. The patient came to hospital after 4 hours. We resisted the patient. We took for replant. And we did replant. We finished after 8 hours. 8 hours of marathon surgery, we did the replant. But arm is viable. But if you see after 4 days, the skin has become necrosed and all muscles went for necrosis. So we debrided again and we applied skin grafting. Further, there is a loss. At the end of 6 weeks, he developed pressure sore over the elbow. So that also we did a skin grafting. And finally, after 7 surgery, the patient is like this. Video. This is arm replant. So intrinsic muscles are not recovering. He is using this as a supportive hand. So one more hand replant. First video. This patient that because of interstitial accident, it happened in Thermopylae. The patient came after 6 hours. Already the thumb and index looks little dusky, blackish. Initially, we are very reluctant to replant, but after 8 hours, we took the patient, we did replant. This case came in the COVID period in Stanley Hospital. So we did replant. Initially, it was okay. After 4 days, he developed venous problem. What we are using, we use medical leeches. For venous problem, we use medical leeches. After that, the skin went for necrosis. We tried further, we debrided and we went for abdominal flap cover. Video. So even though it is not a great result, but he is having hand, he is using this as a supporting hand. The patient is very happy. 2 weeks back, he sent this video to me. So this everybody knows, a bilateral hand transplant. This patient named Narayana Murthy. He lost both his arms in electric burns, and we did bilateral hand transplant. That is hand transplant from the brain dead patient. We took both hands. We attached both hands. He was there in Stanley for 6 months. After the surgery, he got married. Now he has 2 kids. Video. He is with the second child. He is a very happy person. He is able to ride motorcycle. He is working in government clinical hospital as an insurance manager. So foot anatomy, same thing. The various reconstructive options for foot also. It's a declaving injury which was debrided and covered with a skin graft. So it's a neurofibroma of the gluteal region, which was excised in totally, and primary closure has been done. This is a very interesting case. A female child of 6 years with vulval contracture. This is very severe deformity. I released the contracture with multiple ejectoplasty. This is the post-operative result. So all burns contracture, initially, if anything which is not healing by 3 weeks, it goes for contracture. So all burns wound, it should be healed within 3 weeks. If you delay it, it will go for contracture. Then you can intervene with the contracture release and skin graft or flap cover. This one patient ran over by bus. Both foot is got injured, and right side she went to an hospital. They advised amputation, but after that she came there and came to me. I debrided and applied back. So finally she is walking after 6 surgeries. We applied back and repeated skin grafting, and only skin grafting has been done. We are able to manage the whole degloving. So free flaps, it's a post-infective raw area. Free flap, ALT free flap. This is a final result. So previously, your diabetic foot, we are not doing free flaps. But even diabetic also, infected diabetic wound also, you do thorough debridement, we can cover with the ALT flap cover. So some of the congenital anomalies, this is a severe macrodactyly. This also somebody advised amputation at the level of ankle joint. But patient, they wanted nail complex. So we did reduction, and part of the nail complex we retained. So patients and parents are very happy. This is the post-operative result. So diabetic foot also, diabetic foot ulcers, it is treated by everybody. Surgeons are treating, podiatric surgeons are treating, general surgeons treating, orthopedic surgeon, vascular surgeon, everybody is treating. But the ultimate surgeon will be the plastic surgeon. Because why I'm saying that, so we'll debride the wound, we will cover with the flap cover. So we will achieve primary wound closure. So this is a case of 3-month-old diabetic ulcer, which was debrided, surgical offloading done with callus osteotomy, and local flap has been done. VY advancement flap has been done. The wound is healed primarily within 2 to 3 weeks. Some of the patients with diabetic ulcer, they are roaming around for years together. By giving flap cover, the wound will be healing within 3 to 4 weeks. This is a very take home message. So another case, this is also diabetic ulcer. It was debrided, and after callus osteotomy, I did VY advancement flap cover. The wound is healed within 4 weeks. This lymphedema is a very common problem, but they are not coming for surgery. Lymphedema also, we have a lot of surgery, starting from node venous, and all these surgical options are there. Most of the patients, they don't know whether we can go for surgery or not. They are not consulting plastic surgeons. They are going to local doctors, and they don't know what is things to be done. For lymphedema, various surgeries are there. Reduction surgeries with skin grafting, it gives excellent results. But the patient has to follow lifelong compression garment, all medical management. So finally, it's a congenital syndactyly of the foot. The foot also you can release and put a skin graft. Thank you very much. Thank you, Polachi team, for calling me for this opportunity. Thank you very much.
Now is the time for the valedictory function of CGP.
So we have our valedictory function, following which we have 2 CMEs. So I request all the participants to hold on and have a yeah. Okay. So now I request our state president, chair. Uh, uh, uh. I request our members to maintain silence, please. Now we have our valedictory function. கிடுகிடுன்னு போடும். சரி. Now I request our state president, Dr. P. Sengutun sir, to come to the dais. போங்க சார், போங்க சார். I request our state secretary, Dr. Karthik Prabhu sir, to come to the stage. Dr. Gauri Shankar sir, finance secretary, to come to the stage. I request our past president, Dr. Pragasam sir, to come to the stage. Dr. Madhavan sir, West Zone Vice President, to come to the stage. Dr. Gunashekaran sir, past State President, to come to the stage. Yes, yes. Gunashekaran sir, please come, sir. I request our past Secretary, Dr. N.R.T. Tyagarajan sir, to come to the stage. I request Dr. Dirve Mohan sir to come to the stage. So, thanks. Sir. Dr. Anand Choklingam sir, kindly come to the stage. Now, I request Dr. Suresh, our Joint Secretary, CGP Wing, to say IMA prayer. I request all members to stand. IMA prayer. பேசுங்க புடிமா.
Good evening to all. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from.
Repeat. Kindly repeat once Dr. Suresh says the IMA prayer.
May everybody be happy.
Be happy.
May everybody be healthy.
May everybody be healthy.
May everybody be free from pain. May everybody be free from sorrow.
May everybody be free from sorrow.
May we be the healing cure.
May we be the healing cure.
Beyond every greed and lure.
Beyond every greed and lure. Thanks.
Thank you.
Thank you, Dr. Suresh. Now I request our governing council member, Dr. Tirumuthi sir, CGP Wing, to give efficient prayer. Sit down. You can sit down.
Sit down then. Hello. உட்காரலாமா சார்? மருத்துவரின் பிரார்த்தனை. எல்லாம் வல்ல இறைவா, உலகின் சிறந்த மருத்துவன் நீயே. உன்னை மண்டியிட்டு வணங்குகின்றேன். உன்னிடமிருந்து நல்லதும் சிறந்ததும் என்னை அடைய பிரார்த்திக்கின்றேன். எனது கரங்களுக்கு திறமையை தாரும். எனது மனதிற்கு தெளிவான பார்வையை தாரும். இருதயத்திற்கு இரக்கத்தையும் கனிவையும் தாரும். எனக்கு அளிக்கப்பட்ட சிறப்பு தகுதியை தக்க வைக்கும் வண்ணம் படும் பாட்டினை சிறிதளவாவது போக்கிட ஒன்றுபட்ட எண்ணத்தையும் வலிமையையும் தாரும். என் மனதிலிருந்து நல்ல எண்ணங்களையும் உலகளவு ஆசையையும் அறவே ஒதுக்கி பணி செய்திட அருளுமாறு குழந்தை போன்று உன்னை சார்ந்து வேண்டுகின்றேன்.
Thank you, sir. Now, collaring of flag salutation. Flag salutation. Flag salutation. Sir. What do you?
வணக்கம். இந்திய மருத்துவ சங்கத்தின் உறுப்பினர்களாகிய நமது தேசிய கொடியை வணங்க இங்கு குழுமி இருக்கின்றோம். அதன் மகிமையும் மாண்பும் நமக்கு ஒளியாகவும் வலிமையாகவும் அமையும். அக்கொடி காட்டும் வழி நம்முடைய வழி. தேசிய அமைப்பின் அங்கீகாரம் பெற்ற உறுப்பினர்களாகிய நாம் நமது பொறுப்புகளை உணர்ந்து உண்மையாக நடந்து கொள்வோம் என்று உறுதி கூறுகிறோம். அர்ப்பணிப்புடனும் கடமை உணர்வுடனும் முழு மூச்சாக செயல்பட்டு உலக நாடுகளின் மத்தியில் நமது தாயின் மணிக்கொடி செம்மாந்து பட்டொழி வீசி பறந்திடச் செய்வோம். ஜெய்ஹிந்த்.
Thank you, sir. Now collaring of State President Dr. P. Sengituvan, sir, by our State Secretary Dr. Karthik Prabhu, sir. அது அவங்களுக்கு இது நம்மளுக்கு ஓகே எஸ் 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 Thank you, sir. Now collaring of local branch president myself by our secretary Dr. Raghuram, sir. Thank you, sir. Welcome address by myself, Dr. CGP, IMA TNSB. So, at this outset, I welcome our State President, Dr. P. Sengituvan, sir, our State Secretary, Dr. Karthik Prabhu, sir, our Finance Secretary, Dr. Gauri Shankar, sir, our State Vice President, West Zone, Dr. Madhavan, sir, our past presidents, Dr. Gunashekaran, sir, Dr. Pragasham, sir, our past presidents, and our past secretary, Dr. NRT Tyagarajan, sir, Dr. Diravi Mogan, sir, and all our CGP office bearers, our speakers for the day, plastic surgeons, eminent speakers, Professor Raja Sabhapathy, sir, and all the delegates who are joined online and offline. I welcome you all to this wonderful program, and we are into this valedictory function, which is a 5-day marathon CME, and we are in day 5. So we have finished 4 CMEs before this, and we'll be having 2 more after the valedictory function. Now I request our State Secretary, Dr. Ananda Choklingam, sir, to give his CGP Secretary's address.
Good evening, most respected President, sir, and all the leaders of the IMA on and off the stage, and all the faculties and leaders from the Plastic Surgery Association. In IMA CGP, I would like to stress upon only one point, because many doctors are also in plastic surgery, also they are part of IMA, I think. So, like CGP is a wing which was formed in 1964, and it has been conducting very fellowship courses right from diabetology, clinical diabetology, diabetic food, and infectious disease, and sexual medicine, reproductive medicine. And yesterday we inaugurated a new course which is clinical neurology for general practitioners. So it's a course which is useful for the primary care physicians who can make use of it by joining the course. For that, you should be a member of IMA of any branch. You should become the member of CGP, and then you can apply for the online course, and with the contact classes every month, which will be held at places. So this is the short introduction. I don't want to stand between the next speaker and me. Thank you very much.
Thank you, sir. Next, I call upon our State President, Dr. P. Sengituvan, sir, to give his Chief Guest address and Presidential address, and also a concluding remarks for the conference.
Good evening to everybody. Respected past President and my mentor, Dr. K. Pragasham. Respected past National Vice President, Dr. Gunashekaran. Respected Vice President Madhavan, Honorary Secretary Dr. Karthik Prabhu, past Secretary Dr. NRTR Tyagarajan, past PPLS Secretary Dr. Trevian Mohan, Finance Secretary Dr. Gauri Sankar, and CGP Director of Studies College Dr. Sendil Kumar, Secretary Dr. Anand Chokalingam, Dr. Respected Raja Sabhapathy sir, and all the dignitaries on the dais and off the dais. Good evening to everybody. I think this is the third conference of the CGP. It was started during my period when I was Director of College of CGP. Second year we have started, and when Secretary Dr. Sendil Kumar was there. Now Sendil Kumar became the Director of Studies and Anand Chokalingam. During their period, last year also they have conducted the conference. This year also they have conducted. The number of delegates registered in the first conference is around 1,900. Last year 2,000 and odd. Last year 2,000. This time I think it has crossed 2,500. It is a phenomenal job that they are doing a very wonderful job. Hats off to Dr. Sendil Kumar to Anand Chokalingam. Regarding the IMA membership, I request all the branch president and secretaries to increase the membership and also increase the membership strength in the PPLSS and FSS. The CGP is only for enlightening the knowledge of the general practitioners. You cannot fix the CGP certificate in your prescription pad. So it is enlighten your knowledge and increase the treatment procedure so that you can have the full knowledge about the diabetes, hypertension, plastic, neurosurgery. Yesterday we have inaugurated the essentials in neurology and neurological practice. So more than 6 to 7 courses are conducted in the College of General Practitioners, and every course is very important to the general practitioners. So I request when you are joining the membership in IMA, please include yourself in the CGP so that it will be highly useful to all the members and doing private practice in the local area. So with these few words, thanks for the opportunity. Thank you, one and all. Thank you.
Thank you, sir. Thank you, sir, for your compliments for our CGP team. So we wish we will maintain the same in the next few months of our tenure. Now I request our online guest of honor, our National Dean CGP, Dr. V.S. Prasad, sir, for his words of felicitation.
Thank you. Thank you, Senthil. Am I audible?
Yes, sir. Very much audible, sir. Yes, sir.
Thank you. Thank you. Respected dignitaries on the dais, today's speakers and chairmen of the sessions, and participants on physical and on Zoom. And also I recognize the presence of Professor Arul Raj sir and Dr. Abul Hassan and Honorary Secretary CGP, Dr. Amita ma'am. So, good evening to you all, sir. First of all, I convey my wishes on the eve of Plastic Surgery Day. And I congratulate Dr. Senthil, Director CGP, and Dr. Anand Chokalingam, Secretary CGP, and organizing committee of this academic feast of 5 days state conference of CGP, and especially IMA Pollachi team. Under able leadership of Dr. Sengutwan, State President, and Dr. Karthi Prabhu, State Secretary of Tamil Nadu branch. It's very good opportunity for the participants to enjoy this academic feast for 5 days. First day, infectious fevers. Second day, diabetes and hypertension. And third day, approach to headache. And fourth day, forgot. And fifth day, today, plastic surgery. It's very nice program you have organized, Senthil. I congratulate Tamil Nadu CGP faculty. Today, I think it's very good, very tough to practice because more litigation is there and more Googling of the patients are there. So it's very tough. Unless we are update ourselves with the scientific knowledge, we can't do the practice today. So CGP, what thinks CGP is to update all our members, family physicians, scientific knowledge by organizing this sort of conferences and courses. And Dr. Ravi Shankar is very much busy with the organizing webinars and journal also, bi-monthly journal. So to avoid litigation, we should update ourselves by participating in such type of conferences. And once again, I congratulate Senthil and Ananda Chokaplingam and Tamil Nadu CGP faculty. I conclude by giving an advice to all the participants. Update your communication skills, especially listening to the patients, because it avoids litigation. It enhances the patient satisfaction, which prevents the attacks and litigation. So once again, I conclude with the congratulations to the Tamil Nadu State President and State Secretary and State CGP faculty. Thank you very much. Long live IMA. Thank you, Senthil.
Thank you, sir, for your words of appreciation. We will still live up to your expectation. Thanks for your compliments, sir. We take it as a whole for the entire CGP office team for this year. Now I request our National CGP Secretary, Dr. Amuda Karunanidhi Madam, to give her address. Yes, madam. Please unmute and proceed, ma'am. Madam, it's not audible.
Now it's audible?
Yes, madam, please.
Yes, sir. Respected President of IMA Tamil Nadu State Branch, Dr. Sengatuvan, sir. And Secretary, Honorary Secretary, Dr. Karthik Prabhu, and Finance Secretary, and Dr. Gauri Shankar, and other dignitaries on the dais and off the dais. Warm greetings from IMA CGP headquarters. First of all, let me congratulate the Director of Studies, Dr. Senthil Kumar, and the Faculty Secretary of IMA TNSB CGP, Dr. Anand Chokalingam, for their wonderful job for the past 5 days they are doing. Every year they are conducting the meeting in a very big way. Congratulations to them and to all the faculties. In IMA CGP, we are having 24,580 people as life member of IMA CGP. And Tamil Nadu State Branch having 2,500 members. And we are having 18 state faculties and 34 sub-faculties. But in the sub-faculties, only in Tamil Nadu, we are having only 1 or 2 from Tambaram and Coimbatore. I request all the members to join IMA CGP and to start the sub-faculty also. IMA headquarters are conducting the family medicine course and the echocardiography course, and IMA TNSB is conducting so many courses. I think most members can join this and get benefited. Regular weekly updates and monthly webinars are conducting by us, which are much useful to the family physicians. We are going to conduct the MRCGP exam also. That is it is a recognized degree in Western countries and in Sri Lanka. I requested the members to join with them. In July also, we are going to have our GP exam from July 21st to 26. I request all of you to join. My hearty welcome to our CMA President Dr. Jailal sir and Arunraj sir. Locally, we'll call him as father of CGP. Is very much fond of that. I request all the members to join that also. Hearty congratulations to all the Tamil Nadu faculties once again. Thank you one and all for the opportunity given. Thank you so much.
Thank you, madam. Now I request Professor Dr. Jailal sir, President, Commonwealth Medical Association, to give his keynote address. Over to you, sir.
Thank you, Dr. Sendil, beloved and distinguished our state president, the dynamic state secretary, state treasurer, my beloved brother Gauri Shankar, Dr. Madhavan, and our CGP patron, Dr. Arulraj sir, the president, the dean, the secretary, and the distinguished leaders. I apologize for not able to be there with you. I'm able to see Dr. Prahasam sir, Dr. Gunasagaran, and dynamic Tyagarajan. It is my pleasure and privilege to greet you at this meeting. It is always a pleasure and joy to see to be in Pollachi, especially with the meeting and getting the blessing of Dr. Thangamuthu sir is always a great occasion for me to come into the Pollachi. It is been there many times, but today, unfortunately, I'm held up in outside, so I'm not able to be there. It is indeed, and when we are discussing with quite a lot of people and conducting a program for 5 days continuously, and in every day, more than 2,500 to 3,000 doctors joining from the different parts of the state is something which is impossible, practically quite difficult, which has been meticulously achieved by Anand Sokolingam and our Sendil. And it is a heads up to them, the vision they had, the way in which they organized, the purpose with which they have meticulously executed it, and the impact it has created on that, especially starting with the sleep and all the most important and vital issue the IMA college is able to execute. This is what we wanted. And when the college was flourishing and college was percolating its wings across the country, there was a aim that we will be able to update and upskills the knowledge and skills of our doctors to the ultimate benefit of the patient. So today, IMA CGP is absolutely doing that. When you do not have an opportunity to go to a formal college and get a degree, and where the IMA CGP can enter into their a room and enter into their house through the internet and able to update them. And this will, in the long run, it will have a great impact of having that is the most skilled and most knowledgeable doctors in the society. For that, definitely we need a meticulous planning, which the today IMA CGP headquarters and the IMA CGP Tamil Nadu state is able to be implement that. And it is not that you need to stop short with that, and because the challenges are going to be high, and you need to go ahead and make it a possible all these talks which we have made as a possible literature for the review, or the possible literature for the looking it up, so that we need to make a depository or a repository of all these talks in our website. The only my appeal to the IMA CGP Tamil Nadu state to enhance our website, and it should have all these details, all this program. It is not that one day even, and anytime anybody can have look into that, and it should be in the form of the YouTube. It should be uploaded in that, so that the many times, and when we are in doubt, then we will be able to see to that. And today, the credit points which you are giving for all this is one of the most important thing. The days are not far when our National Medical Council or the Government of India to come out with accreditation of this credit point based on their degrees and diplomas. And when you are acquiring these skills and the knowledge in the form of the credit form, and definitely it will be able to be incorporated into your in the career in the near future when you are going there. It is not that just a degree of one which is going to make you a great man. It is only the additional skills which you are going to be getting training is going to be the most important thing. And in most of the countries, and today IMA CGP is in the form of not only giving this knowledge to give this knowledge to the far off places and the places in the African countries and other Commonwealth countries. So it was also a proposal that the Commonwealth Medical Association will have a tie-up with the IMA CGP so that the courses of the IMA CGP can across the borders, cutting across the barriers of the boundaries, and will be reached to thousands of people from thousands of miles away and benefit them. This is possible only when we have this coherent leadership. That is possible because we have a team of IMA leaders in Tamil Nadu, whether it is the president, Dr. Sengutuvan sir, the secretary, Dr. Prabhu, or the Karthik Prabhu, or our Gauri Shankar. I'm astonished to see, and every day, every moment, every hour, they are in some kind of meeting somewhere in the park, crisscrossing the entire Tamil Nadu and making sure the IMA Tamil Nadu is vibrant, IMA Tamil Nadu is living, IMA Tamil Nadu is making an impact. And even to the extent the Honorable Minister was to say, and he is afraid of the Indian Medical Association than the Government Doctors Association. To that level, today IMA has grown in strength, grown in stature. So this stature is achieved by our social performance, but also by the academic excellence which he has shown, whether it is IMA CGP or IMA AMS. The IMA Tamil Nadu is today in the forefront because of that kind of knowledge skill which we are able to execute, which is coordinated by the our state leaders. So I congratulate them. I thank you them with the depth of my heart for the extraordinary work they are doing. Sendil and Sokalingam deserves a special appreciation because they brought in the high-tech, the ideology into the IMA CGP and brought this to this such a stature of the national recognition. So I congratulate them, and we are all fortunate. We are able to work as a team, work as a people with giving and forgiving and upholding each other. So that trend, I wish and hope it will continue. I'm extremely happy to see the past National Vice President and the past CGP Secretary, the sitting CGP Secretary, the Dean of the CGP. They all are coming together as a team and working. Let us work, and with that vision, that let every member of the Indian Medical Association shall be empowered through this IMA CGP so that they will be the ambassadors of health and peace to the community in which they are living. So thank you very much. I am looking forward to visit Pollachi in the near future and congratulate in person the Sendil and the entire team of Pollachi people, Pollachi, my colleagues and senior people from the depth of my heart. So thank you very much for this opportunity to be with you.
Thank you so much, sir, for addressing the gathering amidst your busy schedule. Thank you, sir. Now I request Dr. Arulraj, sir, to give his address. Over to you, sir.
Good evening to all of you. Our President, Dr. Sengutuvan, Secretary Karthi and Gauri, and all our dignitaries on the stage, off the stage, our Dean IMA CGP, Secretary, and delegates. It's really a happy occasion to participate in IMA CGP event. You may ask why. Only one doctor a human being needs in his life is a family doctor. Not a cardiologist. You may not see a cardiologist, not a neurologist, not a nephrologist, not a surgeon, not even a physician. But he can't afford to miss a family doctor. That is why I am keenly attached to this specialty, and till today, over 25 years, trying to strengthen that in our nation. I am happy to say that Tamil Nadu state faculty is one of the best faculties of IMA CGP. IMA CGP is one of the best wings of Indian Medical Association headquarters. Many had been the secretary, I see Abul there, Jailal there, Ravi there, now Amuda is there. All doyens of our medical profession have geared the, sense of IMA CGP and see that it comes up to a, bigger level. And actually, a lot of forces are there. Only thing is, we should reach to the family physicians. And we must increase the membership, number one. Those who are not specialists, they are family physicians, whether they are qualified or not qualified. In our nation, we have to still increase the qualified family physician. Others also, we should enter them, encourage them and make them as members of IMA-CGP. That is number one. Number two, we should see that the services of IMA-CGP are reaching to them. Any number of courses are there, done. 2 sets are there for Tamil Nadu. One Tamil Nadu CGP is doing, another is national CGP is doing. Both are excellent. And I am trying to get an university affiliation to all of them. Sure, at the earliest we will be able to do that. Then that becomes a highly valid one. And all these things should go. Now coming to the annual conference of Tamil Nadu CGP, which is taking place for 5 days, which is history. No other conference is taking place earlier. Many conferences were going for 4 days. Now they have become 3 days. Now here, Sendil and Chokalingam have done it for 5 days. And they have very ideally placed it between 4 to 7 p.m., wherein doctors will be free to participate. And the sessions also, I love it so much. Infectious disease and diabetes and hypertension, and then our pulmonary medicine, acute medicine. It's a very important specialty. There are many acute medicine specialists or emergency physician specialists or cardiologists, but somebody has a chest pain in the night, who goes to the home? It is only family doctor, not the cardiologist. Cardiologist will come to the hospital and take the patient to, cath lab for a PCI, a primary coronary intervention, do a stenting. First man to see the patient, to give a relief to his pain and recognize whether it is cardiac or non-cardiac and direct to the right person is the family physician. Therefore, I love it, acute medicine. And I think today we are going on with plastic surgery. Excellent program. Very excellent, nicely placed. I could have been I'm much happy if Senthil has added a day for family medicine. Family medicine, ladies and gentlemen, it is a science. IMA-CGP has brought out 3 editions of textbook of family medicine, and we should have had a session on family medicine. Sure, in the next sessions, we'll have it with my great appreciations to the team led by Sendil Chokalingam and team of Pollachi and our Tamil Nadu state and our national AP, IMA-CGP. I am so much happy and congratulate them for their effort, and we will grow IMA-CGP strength to strength, day to day, every day. Thank you all very much. Thank you very much.
Thank you, sir. Thank you, sir, for your appreciation. Now I request our past president, Abul Hassan sir, to give his felicitations.
Good evening, all. Thank you, Sendil. Respected President Dr. Sengutuan, Honorary Secretary Dr. Karthik, Finance Secretary Dr. Gauri, Vice President Dr. Madhavan, Dr. Prakasam sir, Dr. Gunasekaran, and Dr. NRT, and all the office bearers of IMA-CGP, my dear Anand Chokalingam and Sendil, and all the office bearers of IMA Pollachi. It has been a wonderful academic festival. Congratulations to IMA-CGP. I also recognize IMA-CGP Dean and the Secretary. My dear friends, I think there are 2 good things developed. One is update of knowledge. I saw there are so many topics done by very, very young faculties for the past 5 days, covering all the disciplines of medicine. It is nice to see that very, very important topics with lots of good messages are delivered to the attendees. The second important thing I saw that, it added value to IMA itself. It added more strength to IMA. It created a feeling that IMA is doing such a wonderful, meritorious academic activity in the form of academic IMA-CGP Conference 2025. I congratulate Dr. Sendil and Dr. Anand for this particular things happen especially. I also request as the past secretary of the IMA-CGP, I feel that there should be enhancement of courses in the field of skill developments. It will definitely encourage people, as Dr. Arulraj said, the department or discipline of family medicine should be encouraged. For that to happen, our youngsters should come forward to take up family medicine and start a general practice. To get that kind of confidence, they should be given a skill course like primary cardiac care, primary pediatric care, primary trauma care, something like that. There is already a model is there. So that kind of courses will definitely attract more youngsters and also more people to take up family medicine. So I think this opportunity will, this particular conference will lay a foundation for those types of courses. I once again congratulate the organizers and wish all the attendees, and also congratulate IMA State Office for conducting such a wonderful show. Thank you very much for this opportunity. Over to you, Dr. Sendel.
Thank you, sir. Now I request our State Secretary, Dr. Karthik Prabhu sir, to give his address. Meanwhile, I request all our members to please be seated in the hall. Dr. Soundarajan sir, Dr. Trimut sir, kindly help in this. Trimut sir.
Respected President, leaders on the stage and off the stage, good evening everybody. ஒரு காலத்தின் நேரம் கருதி ஒரு சின்ன மெசேஜ் மட்டும் சொல்லிக்கிறேன். We may be thinking, எல்லாரும் நினைக்கிறோம் அகாடமிக் மீட்டிங்கும் வேல்டிக்டரியும் வாட் இஸ் த ரெலவென்ஸ். எல்லா அகாடமிக் பீப்புள் பார்த்தீங்கன்னா அகாடமிக் மீட்டிங்ஸ் மட்டும்தான் இருப்பாங்க. அந்த சப்ஜெக்ட் முடிஞ்ச உடனே they will walk away. But I'm sure you please turn around and see whoever few left here behind are the deciding authorities of the people of academics. Take my word for this. Because we doctors always have the habit, நம்ம படிச்சா போது is a selfish attitude. But policy making is not a selfish arena. அங்க வந்து பொறுமை வேணும், உட்காரணும், திருப்பி போகணும், அப்பதான் அந்த policy will happen. And that policy governs all this high caliber people who are in the best of merit. For example, in the CGP team, and I would like to congratulate Anand sir ஆகட்டும், செந்தில் sir ஆகட்டும். Why this 5 days of marathon? இவ்வளவு credit hours எதுக்கு? For any person to practice, you need so many credit hours for re-registration as per Tamil Nadu Medical Council or even the National Medical Council. Credit hours is important. But how many people really come to meetings? How many people are really into academics? அந்த மாதிரி முடியாதவங்களுக்கு இந்த ஒரு series of marathon programs attend பண்ணாங்கன்னா their re-registration is taken care of. That is the main purpose of having this marathon events for so many credit hours. Both in AMS and CGP, they are doing very, very well. But friends, I need to really impress upon this fact. Whatever governs the salaries of the academic people depends on the sustainability of the hospital. That depends on policy making, which depends on whatever policies we are agreeing to. And that depends on this group who is sitting here who discusses. And that discussion is the fundamental framework where entire cost structure is being planned. So please be very careful, very vigilant, read the demand newsletters, understand what is happening, and implement in your hospitals for a smooth and sustainable practice. And with this, for want of time, I stop here. Any doubts, you're always free to contact us. Thank you for the opportunity.
Thank you, sir. Now I request our Finance Secretary, Dr. Gauri Shankar sir, to give his address.
Thank you, Sendil sir. Most respected President, Dr. Sengatuvan sir, our Honorary Secretary, and the dignitaries on the stage and off the stage. Good evening to everyone. So this is a great example how young people can lead and can take over IMA. So this is a time when our Anand Chakulingam and Sendil sir, both of them are around 45 to 50 years of age, and all the office bearers of IMA now are young office bearers. And there is a great fight between AMS and CGP. Last week, AMS has been taken place in Kadalur, and this time CGP has been taken place in going on in Pollachi. So for this event, there are 3,000 registrations, and now around 570 people are following in the online and Zoom meeting, Zoom line, and also more than 1,000 people were participating in YouTube. So it's very heartening to see that we IMA are providing a great source of inspiration and for the academic activities. And so we have a lot of people have been talking about the IMA, the CGP activities. I just want to stress the importance of how the Pollachi branch is shaping up the IMA. So here is a great leader, Dr. Prakasam sir is sitting there, and he has proved that he is always a legend, and I always admire him that his leadership qualities. So actually, we are all youngsters, and he will say something, and we always say what he's saying, something he's saying, we are listening. So, but of late, I understood that what are the things he is saying are very much practical and very much happening. He will always say that West Zone is important zone for IMA. Other zone peoples don't mistook. So he want to stress the importance of West Zone. I am from Gobichetipalayam. I always believe that Gobichetipalayam and Pollachi are the brothers. And in the same way, Pollachi, Unvalpet and Gobichetipalayam, Satimangalam are always twins. So why I am saying this? So we have done a lot of important things in our tenure. Our secretary has toiled himself and has brought us that minimum wages order. So in that, there is a great contribution from the West Zone, especially from all these 4 branches. So once again, we have proved that we are the people who are standing behind the IMA, and West Zone is the important zone for the state IMA. So please give a big hand for West Zone. And in the West Zone, Pollachi, Udalpet, and Gobichetipalayam, Satimangalam are the major branches which are seeing the upliftment of IMA. So they are the main pillars, and because of the great leaders like Senthil Kumar and like Anand Chokalingam and all the youngsters, Palni from Palni, our Suresh Kumar sir has come, and this is the great time for IMA that young leaders has taken up the IMA and they are bringing forward IMA. So thank you everyone for your contribution, and I'll always congratulate Pollachi, and I'm always very happy to come to Pollachi and seeing that this much of involvement from Pollachi branch, from Senthil Kumar sir, Soundarajan sir, Saravanan sir, Tirumurthy sir, and our Srinivas, my batchmate. So it's very heartening to see that Pollachi is contributing great to the upliftment of IMA. So thank you for the opportunity, and thank you everyone.
Thank you, sir. Now I request our West Zone Vice President, Dr. Madhavan sir, to give his words of felicitation.
Respected President, sir, and leaders on and off the dais. So it has been a 5 days of great scientific extravaganza, especially which has been brought about by the wonderful teamwork of Dr. Senthil, Dr. Anand Chokalingam, and team IMA Pollachi. So having 3,000 registrations for a conference is mind-boggling, and it has been planned and executed in such an immaculate way that only this team can do. And I'm very apprehensive of what will happen next year, because this is a feat which may stand the test of time for years to come. So I thank our team Pollachi for giving me this opportunity, and I'm sure we have been immensely benefited by the knowledge that has been given in the past 5 days. And a small request to all members, all presidents and secretaries of IMA, please do enroll more members, and especially FSS and PPLSs, which is the backbone of our organization. Thank you. Thank you for this opportunity.
Thank you, sir. Now I request our past president and immediate past national vice president, Dr. Gunashekaran sir, to give his words of felicitation.
Good evening, everyone. Respected State President Dr. Sengutuvan, leaders on the dais and off the dais, and the faculty members and all the delegates attending today. I am extremely impressed upon the CGP conference held today at Pollachi with the organizing ability of Dr. Senthil Kumar and Dr. Anand Chokalingam and the team of organizers of Pollachi. Really, it is, as a past CGP headquarters secretary, I know how difficult organizing 5 days program in a great stretch with the eminent faculties and enumerating members more than 3,000 in online as well as live. With this, I congratulate for the efforts taken by the CGP team of Tamil Nadu State IMA and congratulate them and wish them all the success and have a great leadership in future. Thank you.
Thank you, sir. Now I request Dr. Pragasham, sir, our past president, to address the gathering. Yes, sir. Past national vice president, sir. Of course, yes, sir. Yes.
ஏன்னா நமக்கெல்லாம் போஸ்ட் கொடுக்கறதே கஷ்டம். Respected President Dr. Sengutuvan, Secretary Karthik Prabhu, Finance Secretary Gauri, Gunasegaran, Tyagarajan, and Sendil, the organizing chairman and CGP chairman, and Anand Chokalingam, Joint Secretary Rajesh Sengodan, my senior mentor Dr. Ganapathy, Raja Sabhapathy, ரொம்ப நாள் கழிச்சு பார்க்குறேன் ராஜா சபாபதிலாம், மற்றுமுள்ள அனைத்து நண்பர்களுக்கும் என்னுடைய முதற்கண் நன்றியை வணக்கத்தையும் தெரிவித்துக் கொள்கின்றேன். ஆக்சுவலாக இந்த பில்டிங் ஓப்பன் பண்ணுறப்ப நான் வந்திருந்தேன். ப்ராப்ளி அப்போ வந்து பிரசிடெண்ட் எலெக்ட் நான். அதுக்கு பிற்பாடு பொள்ளாச்சிக்கு வந்திருக்கேன். ஒரு ஸ்டேட் கான்ஃபரன்ஸ் வந்து யூஸ்வலாக முதல்ல எல்லாம் வந்து இட் வில் பி கண்டக்டட் ஒன்லி இந்த சிட்டி லெவல், மோஸ்ட்லி சென்னை, கோயம்புத்தூர் இந்த மாதிரி. பொள்ளாச்சி ஒரு சின்ன இடம்னு சொல்ல முடியாது, ஏன்னா ரொம்ப வசதியான இடம். மிக சிறப்பாக வந்து இந்த கான்ஃபரன்ஸை அரேஞ்ச் பண்ணிருக்காங்க. யங்ஸ்டர்ஸ் நல்லா பண்ணுறாங்க. செந்தில் ஆக்சுவலாக 3000 பேர் ரெஜிஸ்டர் பண்ணியிருக்காங்கன்னா ஒரு ஆவரேஜாக 1000 மெம்பர்ஸ் பர் டே இல்லை, அந்த அளவுக்கு பண்ணியிருக்காங்க. சிஜிபி எல்லாருக்கும் தெரியும், ஏஎம்எஸ் அண்ட் சிஜிபி. ஏஎம்எஸ் இஸ் ஃபார் ஸ்பெஷாலிட்டி அண்ட் சிஜிபி ஃபார் ப்ராக்டிஷனர்ஸ். ஸோ இந்த சிஎம்இ வந்து எவ்வளோ தூரம் நமக்கு யூஸ்ஃபுல்லாக இருந்தாலும், ரொம்ப நாள் நம்மளை பிரிட்டிஷ்காரன் ரூல் பண்ணதுனால நம்ம ஒரு கம்பல்சரின்னு பண்ண பிற்பாடு தான் நம்ம ஆளுங்க அதை ரொட்டீனாக பண்ண ஆரம்பித்தாங்க. ஆக்சுவலாக 2012 when I was the president of Tamil Nadu Medical Council, 2002 MCA ஆக்டை பேஸ் பண்ணி இந்த சிஎம்இ கம்பல்சரி கொண்டு வந்தோம். அதாவது 30 hours அப்படிங்கிறது. அது ஆக்சுவலாக இப்போ கோர்ஸில் இல்லை, பட் அதுக்கு பிற்பாடு ஆரம்பித்தாங்க. தமிழ்நாடு ஐஎம்ஏ சிஜிபி தான் ஒன் ஆஃப் த பெஸ்ட் சிஜிபி இன் இந்தியா. இதுக்கெல்லாம் கை தட்டுறது இல்லையா? ஏன்னா இட் இஸ் நாட் ஃபார் ஒரு மானிட்டரி பெனிஃபிட் இருக்குது, அது இல்லைன்னு சொல்ல முடியாது. பட் என்ரிச்சிங் தி நாலேஜ் டு ஆல் தி ஜென்ரல் ப்ராக்டிஷனர்ஸ். ஆக்சுவலாக இன்னைக்கு நான் இந்த டாபிக்ஸ்லாம் ஆக்சுவலி பிளாஸ்டிக் சர்ஜரி பார்த்தோன்னா எனக்கு நான் வெங்கடசாமிகிட்ட 1 மாதம் ட்ரைனிங் போயிருந்தேன் அந்த காலத்தில். ஆர்த்தோவில் இருக்கப்போ இன்ஃபேக்ட் அங்கே வந்து பொழுதே தெரியாது, அவனுங்களுக்கு மதியானம் லஞ்சும் தெரியாது. உள்ளே போனோமா மறுபடியும் 5 மணிக்கு தான் வெளியே விடுவானுங்க, மதியானம் கொஞ்சோண்டு சாப்பிட கொடுப்பானுங்க. அந்த மாதிரி ஒரு ஹார்ட் ஒர்க் டிபார்ட்மெண்ட். அதுக்கு முதலெல்லாம் பிளாஸ்டிக் சர்ஜன்ஸ்னால் ஒரு ஸ்கின் கிராஃப்ட் பண்ணுவாங்க, அதுக்கு மேலே ரொம்ப போனால் ஒரு ஃப்ளாப் கவர் பண்ணுவாங்க இல்லை. பட் வெங்கடசாமி கிட்ட போன பிற்பாடு தான் அவர் சொன்னார், டெஃபினிஷன் ஃபார் அ ஹேண்ட். நம்ம ஹேண்டுனா இதான் நினச்சிட்டு இருந்தோம். ஹீ சேஸ் ஹேண்ட் ஸ்டார்ட்ஸ் ஃபார் த ஹோல் லிம். தட் வாஸ் த டெஃபினிஷன் கிவன் பை வெங்கடசாமி when I was a student. ஸோ இன்னைக்கு இந்த டாபிக்ஸை இவ்வளோ ஃபென்டாஸ்டிக்காக இருந்தது. ஸோ இதை வந்து கிட்டத்தட்ட ஆன்லைனில் ஆஃப்லைனில் இவ்வளோ பேர் பார்த்து பெனிஃபிட் ஆகிறது, அதை விட நல்ல பொள்ளாச்சி போன்ற ஒரு சின்ன இடம்னு சொல்கிறத விட ஒரு தாலுக் லெவலில் மிக சிறப்பாக பண்ணியிருக்காங்க. அந்த பொள்ளாச்சி மக்களுக்கு என்னுடைய இன்னொரு வணக்கத்தையும் நன்றியும் தெரிவித்து கொண்டு இதை ப்ரொமோட் பண்ணுங்க. ஆக்சுவலாக இங்கே வந்திருக்க சீனியர்ஸ் எல்லாம் பார்க்குறப்ப எனக்கு அவ்வளோ சந்தோஷமாக இருக்குது. நான் ஒரு தடவை கங்கா ஹாஸ்பிட்டலுக்கு போயிருந்தேன் ஒரு இன்ஸ்பெக்ஷனுக்கு, ராஜசாமி மறந்துருப்பான்னு நினைக்கிறேன். போயிட்டு அவர் கேட்டார், சார் எங்கே சாப்பிட போகலாம், நம்ம கேன்டீன் இருக்கு, பெரிய ஹோட்டல் வெளியே இருக்கு, எங்கே போகலாம் அப்படின்ட்டு. நான் சொன்னேன், இப்போ ராஜசபாபதி ஸ்டேட்டஸ்னால் நம்ம ஹோட்டலில் கூட போய் சாப்பிட்லாம். நம்மெல்லாம் கீழே இருந்து வந்த ஆளுங்க தானே தம்பி, உங்கள் கேண்டீனில் சாப்பிட்லான்னு. ஆக்சுவலாக அந்த கேண்டீன் சாப்பாடு அந்த 3 ஸ்டார் ஹோட்டல் சாப்பாடோட நல்லா இருந்தது. அப்படி தானே? ஸோ மீண்டும் ஒரு முறை பொள்ளாச்சியில் இந்த மாநாட்டை மிக சிறப்பாக ஏற்பாடு செய்து இவ்வளவு மருத்துவர்கள் இதில் பயன்பெறுவதை தொடர்ச்சியாக நாம் செய்ய வேண்டும். இதற்கு எல்லா மருத்துவமனைகளுமே ஆக்சுவலாக இந்த கிளினிக்கல் தம்பி இதை பற்றி சொல்ல நினைக்கிறேன், ஸ்டேட் செக்ரட்டரி. உங்களுக்கு மினிமம் வேஜஸ் ஆக்ட் வந்து ஒரு மிகப்பெரிய அச்சீவ்மெண்ட்டு, நிறைய பேருக்கு அது தெரியாது. பட் கார்ப்பரேட்டில் வந்து நம்ம மோஸ்ட்லி அந்த சம்பளம் கொடுத்துட்ருக்கோம், அதனால் அது தெரியல. பட் மினிமம், அதாவது ஸ்மால் ஹாஸ்பிட்டல்ஸ் சர்வைவ் ஆகிறதுக்கு அந்த ஆக்ட் நம்ம வாங்காம இருந்தோமா கட்டாயமாக முடியாது. ஸோ இதை ஐஎம்ஏ செஞ்சிட்ருக்கு. ஐஎம்ஏவுக்கு நீங்கள் எல்லாரும் இவ்வளோ சப்போர்ட் கொடுக்குறீங்க, இதை தொடர்ச்சியாக செய்ய வேண்டும் என்று கூறி உங்களுக்கு வாழ்த்து கூறி விடைபெறுகின்றேன். வணக்கம்.
Thank you so much, sir. Now I request our past secretary, Dr. NRTR Tyagarajan, sir, to give his words of felicitation.
Thanks, Dr. Sendil. It's been quite some time since I've come to Pollachi. Anyway, coming to the conferences, the last 5 days of the academic fete that we had over the last 5 days. And hats off to the entire team IMA CGP. There are 9 office bearers in the team, led by Sendil and Anand. And the entire IMA TNSB for making this possible, and to Team Ganga for making it very, like today from the morning, I think a nice workshop followed by very good CMEs and very useful topics. Congrats to the entire team for making this possible, and especially to IMA Pollachi. Congrats once again. Thanks.
Thank you, sir. I request Dr. Dirimohan, sir, to give a few words of felicitation.
Respected President, dear seniors and colleagues, I take this opportunity to congratulate Dr. Chendil Kumar and Dr. Anand Chokkalingam and the entire team for organizing this excellent 5-day CME. It was a well-planned, informative, and a truly beneficial for all of us. Thank you for your dedication and hard work in making it a great success. And congratulations once again to all the members of IMA Pollachi. And once again, thank you all for giving me this opportunity. Thank you.
Thank you, sir. Now I request our state leaders, state leaders to receive our mementos. So can we just take the chairs back, sir? So can we have we stand up in the line so that it will be easy for all of us to, yes. எடுத்துருங்க sir. Yes. Now I request Dr. Ganapathy, sir, senior IMA member Pollachi, to come to the stage and felicitate and give memento to Dr. Sengituvan, sir, our state president. We have 2 more CMEs after this. Kindly stay tuned. Wonderful topics after this. So kindly hand over the memento. It is a good art painting, sir. Thank you, sir. Now I request Dr. Jaikumar, sir, to come to the stage and give a memento to our state secretary, Dr. Karthik Prabhu, sir. First memento, adutha shall. Please come, sir. Thank you, sir. So just now we received our felicitations over phone from our President-elect Dr. Sridhar, sir, since he couldn't join. Thank you, sir, for your blessings. Thank you, sir. Now I request our senior member, Dr. Alva, sir, to come to the stage and give a memento to our past president and past national vice president, Dr. Pragasam, sir. Sir, 3 minutes. அதுக்கு வந்து யார் பண்ணணும்? நீங்க தான். Okay. Thank you, sir. Now I request Dr. Sarwan, sir, to come to the stage and give a memento to Dr. Gauri Shankar, sir, our finance secretary, IMA TNSB. Secret. Yeah. Thank you, sir. Now I request our senior member, Dr. Tirumuthi, sir, to give memento to our state West Zone Vice President, Dr. Madhavan, sir. வேற யாரு? Yes, sir. Thank you, sir. Now I request Dr. Soundarajan, sir, organizing secretary for CGPCON, to give memento and shawl to our past president, Dr. Gunashekaran, sir, and past national vice president. Yes. Yes. Yes, sir. Yes, sir. Thank you, sir. And now I want to myself present a memento and shawl to our beloved Dr. NRTR Tyagarajan, sir. Now I request Dr. Ananda Chokalingam, sir, to present a memento and shawl to Dr. Dirive Mohan, sir, our future. Dr. Aram, sir. அதுக்கு நான் ஐஎம்ஏ போடலாம். நீங்க பேசுங்க.
I request our IMA Pollachi President Dr. Sendil to give memento to Dr. Aram, sir. Dr. Aram, on behalf of IMA Pollachi, please come to the stage, sir. Dr. Sendil giving memento to Dr. Aram. Thank you, sir.
Friends, before the vote of thanks, for a few words about Pollachi and Udumalpet and Coimbatore. Namo Finance Secretary சொல்லியிருந்தாரு, the contributions of West Zone, why this is important, and I really have to tell you this. In the Pollachiல, when there was a field visit from the minimum wages committee, Pollachi, Coimbatore and Udumalpetla, many hospitals were inspected. I can tell you, friends, பொள்ளாச்சி உடுமல்பேட்டில் ஒரு ஹாஸ்பிட்டல், சக்ரா ஹாஸ்பிட்டல், ஒரு 10 பேர் உள்ள இன்ஸ்பெக்ஷன் போன உடனே அந்த டாக்டர் வந்து நம்ம நண்பர் தான், என்ன பார்த்த உடனே கையை பிடிச்சி, சார் நீங்க வேணா இப்போ பாருங்க பிபியில் ரைஸ் ஆயிருச்சுனார். சார், this is not for any fine. Please tell the actuals what you're giving. What is sustainable, not what is on paper. இது நம்ம வெஸ்ட் ஜோன்ல இருக்கிற டேட்டா வச்சு தான் what is happening, what is the ground reality and what was fixedங்கிற முடிவுக்கே வந்தது. பிகாஸ் சென்னையில் இன்ஸ்பெக்ஷன்ஸ் இருந்தது. Whatever on paper did not make a difference, but whatever is the actual has changed it completely. And West Zone was so bold, and thanks to all of us, including me, because we were confident not to have any action, but to find out what is real. And we have found out, and that is a fundamental basis. Adula Pollachila kittadhatta 8 hospitals inspection poirundom. I really thank them for being very open about the reality, which really helped a lot. Adu indha tharunathila sollanungaradhukku I want to tell. Thank you, sir. Thank you.
Thank you, sir. Yes, sir. So actually, friends, we are the main, I always say, we are the main pillars of West Zone, Pollachi, and also the Gopchettipalayam branch with Udalpet and Sathimangalam. Sir was annoying with me, including Erode branch. So we can say that we are proud that we are from West Zone and we are uplifting the IMA. And thanks to the Pollachi branch with superstars like Sendil sir, Soundarajan sir, Tirumurthy sir, and all other eminent people, including the senior Ganapathy sir. And thanks for Pollachi to organizing such a great function. And we, Gopchettipalayam, also conducted an NHB function, West Zone, in a grand manner and in a successful manner. So, and I thank all the IMA members of Pollachi for contributing to this function and the success of this function. Actually, this is the function with success of a grand scale that no one has achieved. This because of Sendil Kumar and Anand Chokalingam that we are having more than 3,000 registration. So please give them a big hand and thank you, everyone.
Thank you so much, sir. Thank you so much, sir. Yes. So now I request our state leaders to just have a group photo session, and then we'll close up with a formal vote of thanks, though we have 2 more CME sessions. I request Dr. Parmeshan sir, our organizing vice chairman, to come to the stage. Our organizing treasurer, Dr. Sarwan sir, please come to the stage. Dr. Kaushik and Dr. Sangamitra, Dr. Purni, and our professor, Dr. Raja Sabhapathy sir, kindly come to the stage. Sorry.
Dr. Sangamitra.
Thank you all our state leaders, and I just request our leaders to give a small press meet to our people in the adjacent campus. And meanwhile, we continue with our CME session. I request our moderator sir to come to the stage.
And I think it's time to give a formal vote of thanks during the tail end of the session with two more CMEs. I thank all our participants in the first line of, because without them, this conference would not have become such a great success. All our online and offline participants. I thank our state leaders who have come all the way to the Pollachi branch. Repeatedly, this is the third edition of this particular CGP conference. I thank our plastic surgeons of Pollachi, Dr. Kaushik, Dr. Sangamitra, Dr. Purni, for their wonderful efforts. And I thank all our speakers for the entire marathon of CME who have delivered wonderful lectures and hold the audience together. We had almost 1,000 participants to 800 participants every day on an average in Zoom at a single point of time, whereas the cumulative attendance was between 4,000 to 4,500. So I thank one and all. I thank all the sponsors who have done the academic sponsors, and I thank everyone, one and all. Thank you, sir. I request our moderator to come to the stage and proceed with the next two CMEs. Dr. Kumareshan, sir.
So getting back to the CME, I think after a long session of a valedictory function and other things, we have a very interesting speaker coming up now, none other than Dr. Ravindra Bharati. Dr. Ravindra Bharati is a very senior plastic surgeon who has got more than 25 years of experience in the field of plastic surgery. He has qualified from Madras Medical College, and subsequently, since then, he has been one of the main pillars of Ganga Hospital. He's a real great surgeon because his mentor, Dr. SR, is also a great. Yes, for his credit, he has got 25 publications, both national and international levels. And, his vast experience in this field of plastic surgery has culminated in two chapters in textbooks of plastic surgery as well. He has got a special interest in cleft and craniofacial surgery, and he has done more than 2,500 cleft, lip, and palate surgeries now, and all those are free under the Smile Train program in Ganga Hospital. So he's having an extracurricular activity interest in photography. Please be friended with him in Facebook. You can see beautiful birds being photographed and posted in the Facebook. He very often does that. And he's also a Tamil Arvalar. So நண்பர் அவர்களை இந்த பரந்த அனுபவத்தை பகிர்ந்து கொள்ள அழைக்கின்றேன். நன்றி.
Thank you for the kind words, Kumaresan. At the outset, I'd like to thank the IMA Pollachi and the plastic surgeons for giving me the opportunity to share our experience in plastic surgery and the versatile procedures we do for the benefit for the common medical practitioners. So when you say plastic surgery, it's still a poorly understood word. Already Dr. Jaganmohan sir has told what we do, why we do. We always get a question whether we use plastic in surgery, and that also has led on to some social memes. If we bring the plastic, whether the charges will be reduced. And there is some media hype that there is no scar when a plastic surgeon operates. This talk tries to throw some light about plastic surgery. As we already know, it is derived from the Greek word plastikos, which means to mold. Like plastic is molded into various shapes, we mold the body tissues to the desired shape, either it be bone or the soft tissue. When you look into the spectrum of plastic surgery, we don't have a specific boundary, like in case of a cardiothoracic or gastrointestinal. We operate from head to foot, and we are the problem-solving people, whatever be the etiology, trauma, cancer, etc. That shows a spectrum of cases which we deal with. So as we say that we start from the head to the toe, this is a case of a craniosynostosis. On the left side, you see that there is a child with a plagiocephaly. That's due to the premature fusion of the coronal suture and the flattened. We operate and get the picture like this. What goes on in between is this. We open the skull, remodel it, and put it back to get that appearance. Second is a case where we see this is a patient who presented with a frontal and a parietal defect due to that was removed due to epidural abscess. Normal course of events, this will be covered with either a polymethyl methacrylate substance or a pre-designed titanium plate. But in this case, since it was a infective etiology, they wanted to have autologous reconstruction. So what we did, we harvested about 15 centimeter of alternate rib, and that was split into the outer and the inner layer, and that was fixed like this along with the screws. That shows the late X-rays wherein you can see all the ribs which are fixed. And the CT scan shows the ribs in place, which give the protective function to the brain. This another offshoot, microsurgery, is the marvel of modern plastic surgery, where we have a ripped off scalp, which was brought like this, and which we are able to place it back. Scalp is a specialized tissue which cannot be mimicked by any other structure like the other replacements we do. And this gives a very good aesthetic appearance. And cleft lip in the palate are the events where we know the plastic surgeon to be operating. Not only we deal with the primary repairs, we also do the secondary deformity correction. And third is the velopharyngeal insufficiency. By this, we mean improving the speech. That's a bilateral cleft lip child, and you can see the final picture. And that's a close-up wherein you can see the appearance. And the nasal appearance also comes out well. This with the bilateral cleft lip and the final result. This shows a child which has grown from the infancy, and this boy is about 14, 15 years old, wherein we can see the good appearance retained, and the nostril shape is also quite good. So this another child where we operated with what we call nasoalveolar molding. What we do when they come to us immediately within a month or so, we can do a nasoalveolar molding which can improve the appearance of the nose and better the chances of lip. That's a child which after growth, you can see the nose and the lip which has settled down.